Okay, welcome back from lunch. I'm Jim, the old guy on the board. I survived the AI winter, and I'm here to talk about it. Thank you for coming back. This afternoon, this is actually the best. This is going to be the most fun of the entire couple of days, because you're all here, and this is where we're going to move into the reality-based stuff. And I get it. There was a lot of reality-based stuff this morning. But first we're going to move into a topic that we've not touched on in the decade this conference has been ongoing, and that's global health. And then we're going to move into a presentation that it's not a typo it really goes for an hour and a half, and it's going to be a Duke extravaganza. But first, let's start with global health. Rajan Dewar has been here for a couple of years, another one of the Michigan folks, a pathologist who has, again, done a relatively unusual thing and has moved into global health. So we're going to, with no further ado, bring Raj up, and we will learn about moving ML into the very difficult space of low and middle income countries. Thank you very much.
Thank you, Jim. And it's a pleasure to be here, and I thank the Michigan folks who invited me to be part of this esteemed group. I'm a pathologist, and I'm at the University of Michigan currently. Came here about 3 years back. But before that, I was in Boston, and I started this global health project. The link of machine learning in global health is what I'm here to talk about. Some parts of this has already been covered yesterday. Professor Pilar Osorio, she referred to health disparities and what machine learning can do. That's actually one of the topics that is close to my heart, and I'll be covering that a little bit in the first part of the lecture. And what we did with pap smear reading and machine learning is a crux of my talk. And finally, in the last few slides, I will cover how existing data sets can be used for population health, not just in the United States, but also in the rest of the world. So I'm a pathologist, and I'm also the hematology lab director here at the University of Michigan. We pathologists, most card-carrying pathologists, do cancer work. We mostly do cancer diagnostics, and as you can see here, we look at glass slides and make a diagnosis of cancer. We also actually manage massive data sets which comes out of blood testing, which is CBC, comprehensive panels. Those all go through the lab, which is under the control of pathologists. So pathologists do control data, but most of the time we are just stuck to our microscopes doing pathology-related cancer diagnostic work. We pathologists, one of the major contributions of pathologists to the world of cancer is the pap smears. When Dr. Pilar Osorio, she spoke about healthcare disparities, she mentioned about gaps in care. So healthcare disparities in the cancer context, there are two major diseases that is kind of being taken care of in the advanced or developed world, which is still a big problem in the developing countries or the low and middle income countries. The two major cancers are cervical cancer, and the second one is pediatric leukemia. I won't talk about pediatric leukemia, but suffice to say that while about 80% or more of pediatric leukemia in the developed countries survive, 80% or more of pediatric leukemia, childhood leukemia in low and middle income countries die, sometimes even without a diagnosis. So now coming back to pap smears, pap smear was kind of discovered by this guy, George Papanicolaou, in New York, and that was in 1941. Since the United States and other advanced Western countries developed a systematic way of screening women with the simple pap smear, the incidence of cervical cancer has drastically come down, about 70% in 2 or 3 decades in the United States. This is Canadian data from British Columbia. Again, have come down from what exists to be about 35 to 1 or 2 per 100,000 women. The story is completely different in low and middle income countries. This is the simple pap smear. These are the glass slides that one can see various versions of the pap smear. And these are the cells a pathologist or a cytotechnologist looks at to make a diagnosis of cervical cancer. The simple truth is that this is not available in the rest of the world, low and middle income countries, and that by itself is the cause of the increased deaths of cervical cancer in these regions. The region that I work in South India, and in India, there's about 75 or 80,000 cancer deaths, preventable cancer deaths from cervical cancer alone every year, about twice the number of women in the city of Ann Arbor. This map shows the healthcare disparity that I was talking about. The pink and sort of gray areas is where the cancer incidence is very low, but sub-Saharan Africa, South Asia, Latin America is all countries where the cancer incidence is pretty high. This is called the global divide, disparity in its peak. And in fact, I think this is called the global north, all the developed countries, and this is called the global south. So this has been going on for some time, and this is a story that was shared by Peter Berman, a public health professor at the T.H. Chan Harvard School of Public Health. In 2001, he was the World Bank chief stationed in New Delhi, and they knew that this was a disparity solution. The World Bank knew that it was a disparity problem. So when the government asked them for money, the World Bank said, you have to come up with a solution for cervical cancer. You cannot neglect this anymore. So the government did scramble to put together a program for cervical cancer, and unfortunately, they implemented a test called VIA, or visual inspection with acetic acid, which was a suboptimal, substandard test for cervical cancer screening. And what we are seeing after 18 years is that it's not made a big dent in cervical cancer incidence. Cervical cancer is still existing as it used to be 2 decades ago. This was around the time that I started getting involved. I was in Boston at the time. I started looking at why is this a problem in countries like India, whereas it's been taken care of. And so I thought that it was mostly an awareness issue. People do not know more about it. So I was focusing more on provider education, patient education, getting people to camps, etc. And we were able to get people to come up for cancer. But beyond that, there was something else which I kind of accidentally found out. So this is a typical village in South India that I visited, I think in 2010. And you can see that this little village of about maybe about 2,000 people has a bunch of kids, and there's one kid holding up a bottle of Coca-Cola, a Coca-Cola product called Sprite. And Coca-Cola was readily available in this tiny little village in the southernmost tip of India. So there was not just people. You know, if you go into an institution called IIT Madras, there's monkeys not just drinking Coca-Cola, they're addicted to it. They prefer Coca-Cola to water. And so Coca-Cola is available freely everywhere, much more than probably water, but a simple pap smear is not. So I asked the question, if Coca-Cola is available in the nooks and corners of India, why is a pap smear not available? I wasn't the first person asking this question. A supply chain expert by name Prashant Yadav had done some extremely good work on malarial drugs, and he actually studied the Coca-Cola supply chain and compared it to anti-malarial compounds. And I actually challenged him to study the pap smear as an issue. Why is a pap smear not available? What are the supply chain issues with the pap smear? And we came up with a couple of things. One is the infrastructure required for laboratories is not available in these countries. And the second one is the biggest one, is the skill set required to read the pap smear slides. Even if we make labs, and if we make good quality pap smears, there should be someone to read it. So these two were the challenges to solve. So we went about systematically solving it. We would establish very simple small labs such as this in basically a corner of a doctor's hospital, and supply them with a microscope and staining supplies and train some lab staff to do some simple stains. So these kind of labs were very easy, not too expensive to establish, and we actually started focusing on bringing up lab infrastructure. We had a pathologist at the time, but as the volume started increasing, we needed to actually solve the slide reading problem. So we actually started taking the lab technologists and trained them in the use of microscope and in actually reading those pap smear slides. We actually got a lot of volunteers from the United States who would travel to India, and these are some of the volunteers who actually participated in the Cytoscreener, the lab technologist training course, and they would train about 3 or 4 lab technologists. Some of them would leave, and it was still an issue, but we were able to actually train many lab staff in reading pap smear, but most of them learned very well how to stain a pap smear, very good quality pap smear. So it's again, this is not a new thing. This is what we were pretty much reproducing what was going on. This is a picture from Shelbyville, Tennessee in 1955. When cervical cancer was a big problem in the United States, the solution that the United States had was to train lab technologists to read the pap smear slides. So nothing new. We started training similar lab technologists. This is my pathologist on the ground, Dr. Geeta Jairam. She had dedicated her life to this problem, and she trained these 5 lab staff to read pap smear slides. So it took about 3 years, but our lab staff actually did a phenomenal job of training, not too intense training like how you would receive in the United States, but very slow, mellowed down courses, about 1 or 2 weeks of contact class every year. And then they were just reading from the slides. They were actually training from the high volume of cases that we were getting. And in about 3 years, they were as skilled as any lab technologist here in the United States. So that was actually a big solution for us. They were able to handle about 100 cases per person every day. They could stain and read the glass slides, and we were able to issue a diagnosis in most cases. So we created about 6 laboratories in the southern state of Tamil Nadu. And we started actually exploring other states such as Assam, Rajasthan, and Maharashtra. And we started scaling up, and we needed more and more of these infrastructural needs. So remember the monkeys? We were not going to train monkeys to do pap smear reading. I just put that up. But another solution was we had these 2 options. We can either have similar human power, scale up, and train more and more people to read pap smears, or coincidentally, we actually had some computer vision scientists who actually joined our group, who I knew from my graduate school days, who are willing to help, that we started playing around with machine learning or actually automated image processing for pap smear reading. So by that time, I was really thinking that technology is the solution for the cervical cancer problem in India. Some of the things that we tried to do was have a paper-based chip, about $2 paper-based chip to identify HPV genotypes that are linked to high-risk cervical cancer. But that did not actually capture the entire problem. So the computer vision for pap smear became our big focus. So this is our collaborators from Boston University, Natalia Rodriguez, who's not here, Kathy Klaprish, Mario Cabodi, and a couple of graduate students. We actually developed a very nice paper-based chip for HPV genotyping. But coming back to the pap smear problem, we were trying to recapitulate what a human person would do. So this is about the year 2013. A simple pap smear test involves a speculum collecting a good quality of the cervical smear onto a glass slide, swabbing it, putting it under the microscope, scanning the entire slide. This is what the human person would do, and then observe the cells under the microscope and make a determination, cell by cell. Is this normal? Is this abnormal? So we actually tried to recapitulate that process by computer vision, and this is what are the two big tasks that we had to undertake. The first one was we had to capture those cells from at a very high quality, and the second one was classification of the image, of the cellular image, as either normal or abnormal. So the scanning was one issue, and the second was classification as such. This is the clunky prototype that we developed. This is in IIT Madras, an Indian Institute of Technology in Madras, which is actually a pretty good institution. And we had about 6 iterations of students, grad students, who would actually tinker on this for about 5 years to get where we are currently. But we used a very simple, low-cost microscope. One of the limiting factors was cost. I had this benchmark of a pap smear should not cost more than $1 for us to actually do population-based cervical cancer screening in India. So that $1 has now changed into 100 rupees, which is close to $1.6, $1.5 or so. But that was one of my benchmarks. I did not want to develop a device. I did not want to have a diagnostic that would break that 100 rupee barrier, and that was based on what the government was telling. The government was telling, we can't afford to spend more than 100 rupees, $1.5 on a single person for population-based screening for cervical cancer. So that was a tall order. So we used very low-cost components. That's a simple a dynolight microscope, a single objective microscope, which is connected to an X, Y, and Z stepper motors, which can take the microscope in X, Y, or Z axis as we need it. And then the rest of it is just a simple computer. And as you would know, as I will tell you later, it did need a large capacity for storing image sizes. So some of the issues that came up was a simple conventional smear, as we would call it, had several issues. It's not the same quality as what we would get in the United States. There are some better quality techniques for making pap smear slides called the liquid-based cytology. Unfortunately, these were, again, increasing the cost for me, so I was kind of stuck on this low-end conventional smear, which is taking the cervical sample, smearing it on the glass slide, and putting it on the computer. Would that work or not? And that ended up creating more challenges than needed for us to create this, this microscope, this automated screening system or the microscope. The problem was when we did conventional smears, it needed a lot of focusing up and down. The cellular smears were totally unfocused. They would not form what is called as a monolayer, which is very, very important to form a single plane of vision at this 40x high power field. So we actually started spending a lot more time than necessary, and thinking back, this was a kind of a waste of time on how to fix this problem of focusing. And we came up with simple solutions, but it involved too much time on a single slide. So going to a field, going up and down, adjust it, and get the maximum pixel density from a given layer. And till that is achieved, the microscope or the stage will not move. So it'll go up and down and find out the maximum plane where the pixel density was at the maximum. So this I would tell you later that we needed about 10,000 images from a single glass slide. This would mean that it took about an hour plus to scan a single slide. This was prohibitively high, and in our next prototypes, we will be improvising on that by forming monolayer of cells. Okay? So that is the autofocus system, basically to get a high-quality, highly focused image of the pap smear slides. The second portion of it was to actually analyze the cellular images into positive or negative? Is this normal or abnormal? So for that, we actually came up with a very simple system of an edge detection-based algorithm, segmentation of the nucleus from the cytoplasm. These are kind of pseudo-colored, or actually this is the color of the cells. They have different colors based on their cytoplasmic carbohydrate content. And the amount of nuclear material, the amount of DNA in each cell was an important thing, and segmenting the nucleus from the cytoplasm was the first step that we had to do. So we created grayscale images of each of those cells and used a Gaussian mixture model, which is a pretty standard technique available for us, and we're able to actually classify cell segmentation by using this GMM, Gaussian mixture method, very successfully. So some of the problems that we encountered, I was telling you that we didn't have really high quality pap smears. Some of the issues with pap smears, even routine pap smears, even with liquid-based preparation, beyond just the monolayer of cells, was that if there is a bacteria prevalent on each of the cells, that can be read as a noisy background. Inflammation, cervicitis can cause a lot of neutrophils that will actually obscure the cellular features. So cellular feature extraction became an issue when we encountered all these things. Stain precipitate, a really good quality stain is an important attribute to a good quality pap smear. We didn't have, when we started, some of the issues such as stain precipitate would actually mess up the image. The human mind can actually bypass that. We can actually discount that as a problem, but the machine was struggling with some of these stain precipitates as real things, and it will actually cost more time trying to focus on stain precipitate than the cellular events. And then cellular crowding and focusing. So cellular crowding and folding of cells over each other would cause artifacts such as this, which the machine was struggling, but human beings would not. So they would just move on to the next field, but the machine would actually struggle to try to focus and get a better image of that. This is actually, it's nothing new in the Western world. Automating the pap smear slide has been existing since 1995 in the Western countries. But a low-cost system has never been developed for deployment. These are essentially the difference between a normal and an abnormal. And as you can see, the nuclear cytoplasmic ratio, the more the nuclear cytoplasmic ratio, the more malignant the cell is. The higher the nuclear DNA content, the more malignant the cell is. And we taught the computer to classify cells based on the higher DNA content or the high nuclear cytoplasmic ratio by just segmenting the nucleus from the cytoplasm and coming up with a Gaussian distribution. Okay, so this is our segmentation algorithm. I won't spend too much time on it, basically trying to show that if we segment the nucleus from the cytoplasm and coming up with a metric saying that this is how big the nucleus is relative to the cytoplasm, we could actually come up with, is this a normal cell or an abnormal cell? So these are the steps, just recapitulating, identifying cervical epithelial cells, segmenting them from the background, and then coming up with segmenting the nucleus from the cytoplasm and coming up with a metric of how big is this nucleus as related to the cytoplasm. So we were able to do all these things, and for us, the gold standard was what would a human person call it, and compare what our machine would score it as. So this is some of our initial prototypes. It shows that the machine was behaving quite well compared to the technologist. The machine was overcalling in about 65 out of the about 180 cases that we had. And in about 35 cases, the machine was undercalling or losing or missing some of the cancer diagnosis. So our prototype was something simple with a closed model having an XYZ stage adjuster or stage scanner, and then a simple single objective 40x microscope connected to a controller and a computer, which would actually make the diagnosis. A simple, from a clunky prototype to a simple box structure was what we aimed for, and we have a prototype which is somewhat similar to this. So this is, we call this microscope as Maitreyi, which also means a girlfriend. This was patented and developed at IIT Madras, and it is ready for prime time. We have started implementing this in our labs and generating more data, but we are actually trying to solve the pre-analytic problem. I will be talking a little bit about this. One of the biggest problems with automated solutions in low and middle income countries is the quality of the specimen itself. Controlling the quality is an important thing, so the pre-analytics is what we are focusing on to get better automated computer-based diagnostics for cervical cancer screening. So we presented this a couple of big events, including the computer vision a couple of years back, and we got good reviews. But I have to tell you, this is not, we are not the only ones, or we are not even the first ones here. I think there is a lot of AI-powered companies out there in low and middle-income countries, including India and China, and they are actually deploying and delivering several of these products. The two other companies who have similar products, one is called Aindra, and they actually have a product but for liquid-based cytology, and the other one is OptraScan. So they claim that they have an AI-based solution for cervical cancer screening. We haven't tried that, but I've heard that the quality is pretty good. The point about these is that we tend to think that low and middle-income countries is not where AI or data analytics or machine learning is helpful. On the contrary, it's heavily there. There's a lot of companies out there in India and China focusing on machine learning or deep learning or AI-powered medical technology. So I wanted to cover a little bit about China too, because the three countries that I've been focusing my work on is Ethiopia, India, and China. If you look at this map that I showed before, the global north-south divide does include, the global south includes China, but the cervical cancer incidence in China is not at all as high as India or sub-Saharan Africa. China does carry a huge population. It's somewhat similar to India in many respects. China's population is more than India. They need to screen about 300 million women, same number of women as in India. But cervical cancer is not as high as in India. And that is because China had been proactive in this field and had deployed a cervical cancer screening solution as early as 2005. This is a paper from two of our collaborators from British Columbia. They've been working heavily in the region of Hubei province and deployed a machine-based solution for cervical cancer screening. Their technology is somewhat much simpler. This is a method which was described as early as 2005. They used a modified I don't expect you to read this, but they used a modified method called the Fulgen stain, which is a DNA dye that would do what is called as a ploidy analysis. So if the DNA content of a single cell is more than 5 times the content of a normal cell, then the cluster would detect that as an abnormal population of cells and would classify that as a possible cancer, which would assist in diagnosing or screening for cervical cancer. So they had the solution as early as 2005, and they partnered with one of our common collaborators, this Motic Medical System. We had the scanner from Motic computers, which is actually one of the lowest cost scanner existing. And they started adding these partners, strategic partners, pretty much in every province within China, and would create this hub and spoke model where the patients would go have their cervical smear collected, and they will have a hub where this is all processed, and this will be uploaded onto a cloud and assisted in diagnosis by their machine learning process. So as early as recent as April 2019, the Chinese deep learning AI, they have a program for AI-based cervical cancer screening. I don't know much of the details other than what is available in the website in MOTIC and this landing, which is connected to one of the universities called Wuhan University. So in a simple process, what they describe is pathologists are scarce, or lab technologists are scarce. Their solution for this is to create a hub and spoke model where the patients would go to each hub to have their cervical smears collected. All the specimens would be collected on and transported to a central laboratory where it will be processed, and the images would be uploaded to a cloud called the landing cloud, and the AI solution there would read the slide and come up with a diagnosis. They, just like in India, the Chinese system does not allow an automated diagnosis, especially of cancer, without a human person. So what they call is a diagnosis suggestion. So this is, again, the same process. The specimen would be collected in the center, and the data would be uploaded into a cloud, and the report would be made available to an expert who actually has to perform the QC and approve of the result. So unless a human person approves or disapproves the result, a diagnosis would not be rendered. So that diagnosis would be transformed back to the doctor, and the patient receives the diagnosis for further intervention. So this is in operation, and China now has been assisting other countries in the region, Thailand, for instance, and South Korea, on creating a similar solution for cervical cancer screening, which is quite high in this region. Thailand and Philippines, Indonesia are all countries with a very high prevalence of cervical cancer in the region. So I think that is what I had with respect to cervical cancer. I'm going to talk very briefly about my other projects in a related area, and then we'll have a few more minutes for discussion. So the machine teaching to augment human training is a requirement, because in order to screen about 300 million, 250 million women, we are going to be needing a large number of lab technicians who would assist in the screening. The second project that we are trying to deploy is actually the phenotype identification. So 250 million women is a large number. Is there a profile that can be identified? So our positivity rate, our pap smear positivity rate is around 1% in the highest cohort, but it's usually less than that. So is there a phenotype that can be identified that can be used for targeting populations that can enhance our positivity rate and reduce wastage? That is another project that we had been trying to do in the last half a year. We just started this. So the phenotype identification, can available social and demographic data be used for targeted screening? And that is actually not been tested so far. The two types of screening, which is opportunistic screening or population-based screening, is a little difficult to deploy, especially when you want to achieve faster results. So how do we go about doing this? This is a picture, again, from the same village that I showed before. How do we identify a woman in the screening age group could be a high target for cervical cancer screening, so that we can target our resources to identifying such a person and have a pap smear or an HPV test done. This is again to show that women in these communities are actually very, very valuable. Sometimes it's the women who actually holds the family together. When young mothers die, the family actually starts falling apart. So when you go to these villages, when you interact with these communities, you see sometimes you see villages where it's not cohesive, nothing works, the school is not functioning well, the children don't go to school, the children are malnourished. Those are communities where the women may have these kind of terrible disease. Mothers are often dying young, about 35, 40 years, and children are being brought up almost as orphans. Men actually don't play a big role in those communities, and something to keep in mind. So women diseases are actually very, very crucial to take care, and machine learning may play a part in solving this healthcare disparities. So this is something that we have been toying around for some time. This is a friend and collaborator, S.V. Subramaniam, from the School of Population Science at Harvard. And he's been mining data from the demographic and family health surveys available very freely. It is a publicly available database. It's a longitudinal database and has information from 1995 for every 5 years. This is actually sponsored by the USAID. And so these data sets and surveys are available freely from both the USAID and IIPS, or Indian Institute of Population Sciences. And they collect a large amounts of data about family health. The nutritional status of children, did the mom have proper maternal care, prenatal care? What kind of contraception does the family have? Family planning activities, vaccination rates. So every family has about 100 to 300 data points, and this is about 200,000 families. For example, this is one data set that SV Subbu just published last month, and that they identified 23 correlates of of family dynamics that can be linked to childhood stunting. So this can predict the 23 correlates from the family health surveys can predict childhood stunting, underweight, or wasting when the child becomes 5 years old. So these kind of somewhat unrelated things, what appears to be unrelated, can actually be tailored or used for predicting childhood stunting. And I'm actually wondering if these data sets can be deployed for predicting what kind of women would need cervical cancer screening, or another cancer which is becoming highly prevalent, breast cancer, in these communities. Another thing that we had been doing, my collaborators in China, from Xiamen University, and actually from Yul Beli's lab, had been doing is automated diagnostics. I'm a hematopathologist, and lymphoma is my interest, and we've actually been doing some real deep learning on tissue-based diagnostics on classification of lymphoma. And we actually have a simple algorithm using deep residual learning methods to identify follicular lymphoma from what's called as reactive follicles with a high degree of accuracy. So this is almost my last slide. I do think that machine learning exists and can be a very helpful factor in even the low and middle income countries. I actually wanted to put this up to show the major differences. So what is marked in blue is the global north, and what is marked in red is the global south. Machine learning does exist in many of the middle-income countries, like India and China, for instance. And there are distinct differences between machine learning and what we call as AI in the healthcare field between these two regions. The global north looks like it is, we do a lot of exploration, but we are very safe in deploying our algorithms. The countries like India and China are actually a little bit more bold in implementing some of their some of the algorithms very easily. So it's kind of appears as if they are a little risk tolerant. There is a regulation in both countries. For example, the cervical cancer screening program in China has to be approved by something called the SDA or CINO, something equivalent to the FDA in the United States. CINO Drug and Administration, which actually takes care of and approves any of the diagnostic devices. One of the bigger or the most challenging thing is I heard some of the earlier speakers complain about data quality and errors. The data is much, much cleaner in this part of the world than there. Obviously, I think that is a huge a problem when we deploy AI-based diagnostics or treatment algorithms in countries like India. But I think that provides an opportunity for collaboration between these two regions so that there can be good quality health analytics. So this is my last slide, acknowledging all my collaborators. The first one is from Sharman University, working on the follicular lymphoma project. Dr. Geeta Jairam, this is the project Samyukta, which have made this microscope, the Maitreyi, and my Indian Institute of Technology Madras friends, Sridhar and Srikant. Srikant is currently at the University of Michigan, and he's actually going back tomorrow to India for good, because I think India is very vibrant in some of these areas. And I got to tell you, my parting word is that I think you are all in a very exciting area of work. Machine learning and healthcare analytics is probably the solution for the raising healthcare costs in the United States, and I think you're in a very hot area. So finally, I also have to acknowledge my current place of employment, which is Centene and US Medical Management, which actually looks at, it's an accountable care organization. I'm one of the lab medical directors looking at lab data, which can predict hospitalization as well as end-of-life care in homebound patients. With that, I'll stop, and we have some time for questions.
We're focused on sepsis here in the United States, and although it is a big deal, the problems you're dealing with have got 2 orders of magnitude more folks involved. Congratulations, nicely done.
Thank you.
Go ahead.
Great talk, very interesting. I just didn't know if you could comment on the fact that there's a little more reluctance maybe in the blue than the red, and if that's from clinicians are more open to such improvements in the red, and also if you thought that the issue with maybe there might be heterogeneity throughout India, in terms of you maybe sample one part of the country, the south, for example, versus the north, you will find a lot of difference, and that's going to be maybe an issue in the long run when you're trying to make models and try to test them in other places.
Sure. Great question. So the first one, are you a clinician by any chance? Okay. So you probably, I think clinicians here are split. I was talking to someone during lunchtime. I think there is more equal partnership here in the United States. I think physician as an interdisciplinary group is an essential requisite for moving any of these things. Whether physicians have an hesitancy in adopting, I do think that there is it is an issue. In India, physicians are very ready to adapt machine learning algorithms, but I don't think they vet it out enough, and so there is a lot of risk involved. So there is that big difference that I've observed, but I don't have a study to back it up. As far as heterogeneity, of course, it's even within a state, there are differences in communities, and that is where I think the data set based targeted screening could be very, very helpful. North India, if you've been to India, you can see that if you travel about 100 miles, it feels like it is in a totally different place. People speak a different language. There is huge healthcare disparities. I did mention that geospatial data availability is also an important requisite, and I think the data sets are intricately connected with some of the constituencies, And I'm actually looking forward to working with them and seeing if the heterogeneity issue can be solved by geospatial differences of population. Good question. Thank you.
Thank you very much. Well done.
Sure.
Okay, next, actually I should add while Catherine Heller and et al. Are on the way up, we are live streaming this. There have been at least 1,000 hits or hits from different IP addresses. One was mine, just to check. But we are broadcasting all over, not just the U.S., but the world too. These talks are archived, or they are currently online. So if you want to go back and pick up anything, the slides are there and the talks are there. Okay, so it's my pleasure to introduce next Catherine Heller. She is both in, I suppose, the unreal world of academics, but the real world of Google all at the same time. I suspect a life goal of hers was never to be 1K on United, but Duke is on one side and Google's on the other, so if she's not there yet, she'll get there soon. And again, we're going to stay practical. Last talk was practical at a world level. I'm assuming we're staying practical at the US level here? More or less. All right. Catherine, take it away.
Thanks very much. Yeah, so I'm talking about machine learning for healthcare and practice, and by I'm talking about, I mean I'm going to give you a 10-minute introduction, and then I'm going to let the people who I collaborate with, my clinical collaborators, talk about each of the projects that I've worked on at Duke University and how they're going in terms of deployment. Oh, and I forgot my slide advancing thing. Okay. So basically, this talk is about collaboration, and it's about collaboration mostly between quantitative researchers and clinicians, but it's also about valuing teams of people working on things to get things from the level of like a concept to get things from the level of being a concept within machine learning in terms of what you can do in the field of healthcare to being deployed at a hospital or in a healthcare setting. And these collaborations involve large teams of people. And those people have all kinds of knowledge, right? So it can be medical knowledge, it can be all kinds of medical knowledge. So you might need a whole team of specialists that you're speaking to. It can be computational knowledge, right? So you might need somebody who does machine learning research. You might need people who do other kinds of data science in order to translate that to deployment. It might be IT or it might be infrastructure. And you'll be hearing from a lot of different people who've worked on different parts of deployment of, in particular, sepsis. So these teams are really necessary to successfully build and deploy machine learning systems in hospitals or in healthcare in general. So one of the things that I've worked on is dealing with what happens when a patient is outside the hospital, right? So for all of the people who have chronic diseases, most of their lives are lived not in a clinical setting. How do you start collecting data on people in that situation? How can you make decisions to make people's lives better when they're not in the hospital or admitted on an inpatient basis? And so there are a whole bunch of things that I've noticed as I've gone through trying to work on these teams or working in collaboration with whole groups of people. And one is the idea of devaluing other people's areas of expertise, because this happens a lot, right? Everybody is very prone to thinking that the thing that they do is really awesome. But if you go into a collaboration thinking that you're way above like everybody else you're talking to, your collaboration isn't going to go very far, and other people are going to get resentful. So somehow thinking that your own field is inherently superior is probably not helpful. Okay, so there have been a bunch of hurdles that we've come across trying to do machine learning for healthcare, and I'll talk a little bit about some of them here. So hospitals, so first I'll talk about hospitals. There are drawbacks to every place. I'm just choosing to start with hospitals. So hospitals are large bureaucratic organizations, and their main job is to provide care for patients. And so the thing that they value, or the thing that I've seen them really value, are day-to-day operations, right? A patient comes in, they're sick, they want to make them better right now. They're interested in doing the same thing today that they did yesterday, and they are almost too busy to consider innovation often. So they see change as a potential liability. What happens if we have a patient and we don't make them better and we could have, right? Whereas I see change as something that can really improve your ability to do healthcare. Business is at the top, right? So when you talk to hospital leadership, you often have a group of people who are really concerned about cost, and that's probably regardless of what country you're in. So we've had this happen. A clinician might be very happy with the kind of innovation you're presenting, but the hospital leadership isn't seeing the cost savings, so they're like, I don't really care enough. That's really disheartening. Anyway. So there are also places that really value medical doctors. And so PhDs are often seen as people who kind of like do power calculations or something like that. And so at Duke, even the IT department is largely run by MDs, which is very questionable to me at best. Okay, so another experience I've had is the experience of working on an app, and I'm thinking largely on an app for the purpose of trying to collect data about people outside of a hospital or clinic environment. And this presents its own set of challenges. So one of the challenges we've had is that apps are incredibly expensive. Of all the research that I've done, of all of the projects that I've had, this is probably my most expensive, not probably, it is certainly my most expensive project. And so where does the money come from? And that's a really tough question. And it's hard to get grants, so often federal agencies don't really consider the development of apps research. So like the data analysis might be research, but the development of the app itself, and the data analysis costs very little in comparison, but the development of the app itself is not really research, so they don't want to pay for it. And so even if you are doing something like you're getting a grant for the analysis, the machine learning analysis of the data coming out, it's hard to get money for the actual development of the thing whose data you're analyzing. Okay, so apps also have, there's a lot of moving parts in these projects, right? So you need to contract out with a lot of people or work with a lot of people, right? So there's like front-end development of the app, there's back-end development of the app. There are questions like, where is your data getting stored? None of these questions are potentially really new, right? Like, it's got to be HIPAA compliant. What's HIPAA compliant? What's HIPAA compliant? Varies institution to institution. There are a whole bunch of problems, and you need to face every single one of them if you want to get data out that's reasonable. Okay, so things are really, really new in this setting. I'm really excited, actually, about this setting. I think that this setting is going to make a huge amount of difference in the lives of people and the healthcare of people in general once we can start collecting data on them. But it's not there yet, and it's kind of scary, which I'll get to. Okay, so collaboration in academia or in tech industry. So these are kind of, in some ways, polar opposites, right? So if you're talking about an academic hospital setting, you're talking about a setting that really values medical doctors, and they don't really quite know what to make of PhDs. And when you're talking about the tech industry, you're talking about a company of people who really value PhDs, and they don't know quite what to make of medical doctors. So if you talk to a hospital will often be like, I don't understand exactly what quantitative people do, or more often they think they know and they really don't. And if you ask a tech company, tech companies are confused about what clinicians do sometimes. Like, one of the things I've heard in tech companies is like, we have a doctor. And I'm like, okay, that's great. I just came from a hospital of 3,000 doctors, and like they're like pathologists or pediatricians or something. And that kind of concept is I think not always as present as it should be. Hospitals, where the computational resource is coming from, that's something that they often don't know, right? These are not institutions that are set up to have a large swath of computational resources, whereas tech companies are. They don't have a problem with computational resources, but where is the access to patients or even providers coming from, right? They have to work with a hospital in order to get access to any of these. And everyone, regardless of whether you're an academic hospital or a tech industry or a tech company, is very concerned about getting sued or their public perception. And so it's not clear to anyone how people should be innovating, because to do something like I'm talking about, to improve the lives of people who are, say, living with a chronic disease at home, you have to be collecting data about people at home. And once you're talking about doing that, you're talking about everybody freaking out about the privacy of their data. And so it leaves a lot of open questions about where can we make progress versus like where, is the New York Times going to get a hold of it and write you on the front page and say that you're really bad. Okay. The last thing I wanted to kind of sneak in there was dealing with people and emotions. And this is kind of like broadly, I would say broadly a theme in this area of work, and actually in other areas. I do a lot of work for diversity and inclusion, and it's kind of an issue there also, right? So being able to deal with other people and the idea that other people have emotions sometimes is something that quantitative people in particular are not always really good at. And like the number of times actually I've had somebody in a quantitative field come up to me and be like, but you're expecting me to deal with that person's emotion? That's a burden. And it's like, yeah, that is a burden, I guess, but being able to deal with people and the fact that people have emotions is something that's really going to be beneficial to your collaboration, and it's really gonna benefit you in life in general. I would say that this is like competency, right? Like this is part of being a competent person. And you're all laughing, but like our previous speaker was just up here and was talking about villages where the women die and it falls apart and children starve, right? Because like, I don't know, the guys can't get it together or something like that, right? Right? Like men are competent people too. And I think that we have to start expecting from the world in general, from a diverse set of people, that they act like the competent people that they are. And so understanding people from a variety of backgrounds is really important for functioning in a more diverse world. Okay, so the outline of this talk. So first, Mark is going to talk about sepsis with a whole bunch of other people, and I will let them introduce themselves one at a time. They're going to talk about the sepsis deployment at Duke University. Kristen is going to talk about surgery, and Lee is going to talk about our multiple sclerosis app. I will very, very quickly remind you that there is machine learning methodology behind these. So for sepsis, there was a Gaussian process combined with a recurrent neural net framework that we had a paper on at ICML and at MLHC in 2017. And it's really cool. And there was a whole bunch of related work, actually even presented at this meeting, coming off of that. And this is what you're going to see implemented in the sepsis detection stuff at Duke. There is also work by my former, that was by my former student, Joe Futoma. There was also very interesting methodological work done in surgery by my former student, Liz Lorenzi, having to do with hierarchical infinite latent factor models and about clustering CPT codes. We didn't actually deploy any of this. What we deployed is a sparse logistic regression kind of pipeline for predicting whether or not somebody has surgical complications, and Kristen will talk about that. And lastly, Lee will talk about the MS app that we've developed, and the master students tried a whole bunch of methodological things that are much less sophisticated, including like logistic regression and some basic clustering methods, et cetera. And hopefully there will be more new cool methodology coming out of that. Okay, so this is my last slide. I just wanted to say thank you to everybody. It's been a real pleasure working with all of you, and it's just been great. And so everybody, Hopefully everybody is up there. You can see the sepsis team, the MS team, and the surgery team. There are a whole bunch of people, and they have a whole bunch of roles, data science roles, clinician roles, and everything in between. And now I will let them talk. Thanks.
So thank you to Catherine for letting us kind of take some of this time and walk you through how we've built an ecosystem for integrating machine learning into healthcare at Duke. So I'm going to give you a quick overview of our team. We're going to kind of talk about some principles that we use, which are listed out here: build to show value, build to integrate, and then from models to bedside, build to scale. We're going to talk about use cases in surgery and then go deep into Sepsis Watch, which is our application name. So we are DHI, the Duke Institute for Health Innovation. We have a large team here at this meeting, many students, many full-time staff. You're actually seeing about more than half the team here. So there's a handful of people holding down the fort in Durham. So our mission is to catalyze innovation at Duke. We want to transform health and healthcare, and our approach is by design. We work directly with frontline staff to design new workflows and care models. We have two mechanisms by which we source innovations that we work on. The one on the right, we're not going to touch on much today, or my right, yeah, you're right too, which is more of a Shark Tank competition, and then the one on the left is a top-down, bottom-up approach. And this is the mechanism by which both projects we're going to talk about today were identified from frontline staff. One was around high rates of surgical complications, the other was around poor compliance with sepsis treatment and poor sepsis detection. So when we try to describe what we do in healthcare, it's a concept from economics. It's called a production possibility frontier. So large organizations are typically fixed in their capacity to produce goods. So kind of adopting that for healthcare, you can think about there's a fixed amount of goods that we can produce in terms of low-cost services and high-quality services, and that there would be a trade-off if we wanted to move along that curve. What our team tries to do is try to think about, okay, there's other ways in which we can generate goods and services in healthcare, and there doesn't have to be that trade-off. How do we both develop more low-cost services and high-quality services? So we've grown a lot over the years. I first joined the team in 2014 when we weren't yet doing much in data science, and I'm going to kind of walk us through what the last 5 years have looked like. So in year one, it was just me as a full-time staff starting student programs, and then we had one data science project that was ultimately integrated into operations around chronic kidney disease. This was my first collaboration with Joe and with Catherine. We had 3 in total, 1 startup that was created. Go forward to 2016, we grow a little bit in terms of a team. We're doing double the amount of projects. From that time period, the Sepsis project, which we're going to talk a lot about, as well as continued partnership with our accountable care organization in Durham. The next year grew a little bit more as a team. We're going to talk a lot about the investment that happened starting at this period, and then more integrations into operations. One of these was integrated as a best practice advisory in the electronic health record. Kristen's going to talk about the perioperative optimization. And then Paleolytics was a project that Michael led that was also in partnership with our accountable care organization. So doing integrations both inpatient in the hospital and outpatient for population health management. We get to 2018, now we're looking at 12 projects. Things are growing quickly, still growing the team relatively slowly. And then we're only 4 months into 2019 and already have more than 10 projects that we're actively working on. And what I highlight here is we're doing our first model update. So we've talked a lot about the sepsis model that was developed, but now we're trying to optimize it for other care settings within our hospital. The way that we have grown, obviously, has not been by growing the team at scale. So there's been other types of principles that we've had to adopt as a team. One is build to show value, build to integrate, build to scale. And throughout this, we also try to build responsibly. So what I mean by that, I'm just going to call out a few things here's more of the things that we do, but just a handful. One is model monitoring. So when you enter our office in Durham, it's actually Marshall's office. We have a 55-inch monitor that shows you the current state of the triage page of the sepsis application on the left-hand side. And on the right-hand side, you see the model output. So we have mean, standard deviation, median, number of risk scores being calculated across 3 hospitals. And then the other example is model fact sheets. So how do we distill information that we present to clinical end users so that they are aware of both what the model is doing and how it should be used in clinical practice? So I'm going to hand off to Kristen, who's going to talk about surgery use cases.
Hi, I'm Kristen, and I'm going to briefly describe our surgical projects that we developed from our data asset called Pythia through the lens of DHI's guiding principles, building to show value, building to integrate, and then building to scale. So overall, building to show value is working on the right project with the right team. Building to integrate is designing solutions together, establishing governance, driving adoption, collaboration to train and integrate into clinical workflows. And then lastly, building to scale, so developing the infrastructure to support other projects and not just your project that you're starting out with. So starting out by the first principle, building to show value. So with this set of surgical data projects, we identified this problem. There are around 50 million surgical procedures that are performed each year across the United States, and 30% of those patients undergoing those procedures experience a set of complications, which include anywhere from death to infection, hemorrhage, clotting, you name it. So pretty much the toll on this, on our patients, on our society, and our healthcare system is pretty enormous. Oh, wrong way. So wanting to delve further into this problem, we partnered with an interdisciplinary team of physicians who had started POSH Clinic at our healthcare system. So POSH Clinic stands for the Perioperative Optimization of Senior Health. And basically what they do in this clinic is that they identify high-risk patients who are older, patients who have severe comorbidities, and they try and tune them up for surgeries in an effort to optimize chronic conditions before the stress of anesthesia, mechanical ventilation, and then complex surgical procedures. So trying to minimize post-op complications prior to the procedure takes place. And this is an example of the perioperative journey. They would be identified by physicians, usually surgeons, I guess directed to this clinic before surgery and then hopefully not experience any complications. So working with the right team on this problem, we developed a set of postoperative complication risk prediction models for patients undergoing invasive procedures, and we published this work last year. So one of the biggest problems this clinical team was facing was they were having issues distinguishing those at the highest risk of experiencing complications and then prioritizing those patients in particular for clinic efficiency purposes. So what we are able to do is predict that risk, stratify those patients within a high-risk group, and this task without any support is super challenging just due to the interplay of multiple demographic and medical conditions. So machine learning is perfectly set to handle this task through identifying optimal thresholds. And through, in order to accomplish this, we worked with the team, our clinical team, to identify the optimal threshold, where that threshold should be placed for their specific workflow. So we developed an app for the clinicians in POSH Clinic as a decision support tool. And I think this project was super successful because the problem and the design was, the solution was designed around the clinical question. So one, something that was a problem that was best answered using machine learning. Two, it had a clear implementation workflow within an existing clinic. And 3, the model output, this app prompted specific clinical interventions by providers for patients. But most importantly, that working with this team gave us access to the expansive network through our healthcare system. So the data that we developed to train these models was stored on an open science data platform for the university. It housed 227 clinically curated features for around 500,000 patients. And this caught the eye of the Department of Surgery, more specifically the chairman of the department, Dr. Alan Kirk, which started our team's formal relationship with him and the department. So this department, also quite large, is able to support its own research organizations, including Duke SCORES, which is a surgical center for outcomes research group, and then the Laboratory for Transformative Administration, another large training research group. So by opening up our work and our data and partnering with these large organizations, we're able to support their projects as well as our own, and also grow relationships in our networks. These relationships, these types of relationships, work to build trust between physician scientists and data science technology, and I think allowing for the ability to further advance machine learning in healthcare with the right partnerships. So thinking beyond the single implementation of POSH, our models within POSH, we plan to implement across our healthcare system. And that was how the federated modeling, which I presented earlier this afternoon, was born. So our healthcare system is made up of 3 hospitals that serve 3 distinct populations. So different training combinations or ensembling combinations, which is what we ended up trying, becomes important when trying to optimize models' performance for a specific location. So DHI has developed an automated EHR data pipeline, which will be discussed in detail later in this talk, but it houses meaningful curated data solely for the purpose of data science research. Pythia, the data that was used for our surgical models, is now integrated into that pipeline, which now represents all of the patients within our healthcare system. So furthermore, this pipeline is opened up to Duke investigators, trainees, and administrators for research purposes. So once the pipeline was deployed, one of the first questions we had was, how can we demonstrate quality of the data from this pipeline to its end users? And we started off by just simply calculating variable missingness among this EHR pipeline, and then quickly found this complex framework, data quality framework, which we applied and then also adapted to test the data quality of our data pipeline. This framework was originally developed by PCORNet, which is the Patient-Centered Research Outcomes, or Patient-Centered Outcomes Research Network. So it's made up of three types of data quality analyses: conformance, completeness, plausibility, and then plausibility is then broken out into 3 types: uniqueness, atemporal, and temporal. So this is just a quick example of the types of checks that we are doing on our pipeline. And this example in particular looks at temporal plausibility. So this graph is showing the arterial O2, arterial oxygen levels, and the means over the course of 4 years. And as you can see, so the labels are pretty similar. One's like PO2 arterial, PO2 arterial OR, and then POC, PO2 arterial. And so you would think that these labels would all be pretty much PO2 arterial. However, looking at the means, they mean different things. And so what we found was that the top line, which has a higher mean, these represent patients in the ICU. So these patients are usually mechanically ventilated, increasing their mean PO2 arterial levels. The middle blue line represents patients who had had surgical interventions, and usually those patients undergo general anesthesia, also mechanically ventilated, increasing their PO2 arterial as well. And then the bottom line represents patients on the floor who usually are not mechanically ventilated. So I think by being able to look at this at the local level, our team is able to delve deeper into these data quality issues, learn more about how our healthcare system stores its data, how that data is represented, and then we can translate that into our work. And we can understand our data better and deliver higher quality data to our researchers. So now, after performing this type of work on our data pipeline, all data quality checks are required for all projects using the data pipeline at DHI. So as we continue to learn about certain healthcare data types and build infrastructure around its utility, it opens up a bunch of opportunities to build meaningful relationships, to heighten the quality of our work, and make a real impact in healthcare for our patients. What started out as a super narrow project for one clinic in Posh ended up flowing into a data science platform for our entire healthcare system with formal processes developed in data quality infrastructure. We hope that by presenting our journey as a group, we can serve as an example for data science integration within a healthcare system. So Mark is now going to talk about Sepsis Watch in the context of building to show value. Thank you very much.
Perfect. So the fact that we're here 3 years later to say we did this successfully is not random. And there's reason why this was about sepsis. So just look at the bottom plot. That's going to show you national average, state average for compliance with evidence-based guidelines for sepsis. All three of our hospitals were below average. Our flagship hospital was very well below average. So there was a prior implementation of a best practice advisory based off the news score that failed miserably. So it was firing up to 100 times a day for certain high-risk patients, and it was canceled 86% of the time. So an important takeaway here, too, is that other types of solutions have to fail at solving the problem before people start looking to machine learning and complex technology to implement. Then you need to put together the right team. And this is kind of going back to Catherine's point. This wasn't just one doctor and one statistician. There needed to be kind of a whole network of people around this problem. Not everyone was there on day one, but we gradually put this group together. Another kind of mission, the fact that we're in an academic institution, is also that we always are trying to build capacity. So there were clinical trainees and quantitative sciences trainees kind of distributed throughout this team. You have to engage the right leaders. And part of this is really on the responsibility of the innovation team to kind of have these relationships and have this network of individuals engaged in the projects from the beginning. So the top bullet point, the twice yearly presentations to the C-suite, those are actually standard processes for every innovation project. So every project that gets investment through our team, they have to do mid-year report out and end-year report out to the C-suite, just to make sure that any barriers are removed by senior leadership. We had monthly meetings with the hospital president where we were going live. We had monthly meetings with our health system CTO to make sure that we had the technology that we needed. And then we had weekly meetings. This was leading up to the integration. We had weekly meetings with our CMIO, IT leadership, and actually Epic leadership to do all of the due diligence for how we would be needing to integrate this into the production system. You need to optimize for learning. So it wasn't explicit at day one, but we very quickly learned that we needed to focus on the emergency department initially across all of our 3 hospitals. Here's just another way of visualizing that information. 40% of sepsis in our health system occurs in the ED, and then if you look at the distribution of time of sepsis, the bulk of that distribution is around time 0, which is time of admission. Then you have to build cool tech. You get brilliant people to come in, use things that people are hearing is being applied in other industries. It gets people excited. You start showing how it works. So show how it works for individual patients. As I'm sure you already know, kind of working with clinicians versus technical audiences, different ways of showing model performance conveys different information to different people. So this is an individual patient trajectory showing kind of has as the care delivery course continued during the encounter, how the risk score was responding. And ultimately, this ended up being 17 hours before antibiotic administration and 36 hours before clinical documentation of sepsis. And then you also need to show the other outcome measures for the model. So I'm going to switch over now to Will, who's going to talk about how you integrate these into the clinical workflows.
Thank you. Hey there. Green. Thank you very much. So I'm going to start. I'm Will Ratliff. I'm Innovation Program Manager with the Duke Institute for Health Innovation. I'm going to start with a quote from Niccolò Machiavelli about change. There is nothing more difficult to take in hand, more perilous to conduct, or more uncertain in its success than to take the lead in the introduction of a new order of things. And so really that means change is really tough. He goes on to say, Machiavelli goes on to say that there is only lukewarm support for those who lead change, and the lukewarmness really comes from the fact that we as human beings don't really believe in something until we've tried it ourselves. And so I think that's, in terms of our build to integrate principle, the main point here is to build that confidence and use that build to show value momentum to really overcome that fear of change. So about a year ago today, I joined DHI. I knew nothing about Sepsis Watch and a very little bit about machine learning, so this weekend has been wonderful for me personally. The state of affairs of Sepsis Watch itself was about 2 years old at that point. It was very thoughtfully built, as Mark had pointed out, but it was not yet real to stakeholders. And so that's where, soon after I joined, I saw an opportunity to jump in and help out. And a quick background on me, so my background is in healthcare IT consulting and some strategy consulting as well, so really saw the opportunity to take the ball and just push it over the finish line through our go live, which you see here. So this is the Sepsis Watch pilot implementation timeline. We went live on November 5th of 2018 for 6 months. We are still live today, thankfully. Just wanted to point out on the left-hand side, your left as well, the chevrons, which really encapsulate the build to integrate principle. The first is to validate the workflow and the app, and I'll jump into that in a second, but really to make it real for those who are using it every day. The next is to educate and train on that workflow validation to really make sure that not only the vision, but those who are going to use the app know the next steps as soon as you wake up, go to the hospital and start using it. Also, the importance of communicating the vision. So for those who are both using the app and those who are supporting the workflow and hospital administrators, et cetera, really important to know that vision and to be able to tell your friend when they ask you about what is Sepsis Watch, what the deal is. I think perhaps the most important thing that we found was to create a governance structure to lead and to give a sense of autonomy to help push that pilot through to its completion. And then also something at the end that we're very excited about and is a little bit preliminary, but is to evaluate performance and to really help show the progress of the team. So to help illustrate the build to integrate principle, I wanted to use the framing actually originally from the Leading Strategic Change. It's a book by Black and Gregerson, which focuses on 3 failures. The first is failure to see, failure to move is the second, and failure to finish is the third. So failure to see, that really stems from that Machiavelli quote that fear of change really prevents the start of the acceptance of the new order of things. So as you'll see on the left, sort of some human kind of organizational and just cultural issues that manifest themselves into those responses, and then a couple of tactics to overcome. But essentially it is, a failure to launch. So the way we overcame the failure to see was really, as you might expect, a process map. And that took the form of a 3-hour meeting with all of the stakeholders that you might think of, so namely the rapid response team nurse, who I'll kind of go through in a second. So those nurse managers, the ED nurse and ED physician managers, as well as our clinical champion, Dr. Kara O'Brien, as well as the CNO and some additional operational leads. But essentially it went like this. I would go up to the board, I would draw the first little box where the RRT nurse swim lane is, and then I would say, well, okay, what do we do next? And just would spark a dialogue as one would typically go through a process map. And so to give a sense of how Sepsis Watch works that we were able to dialogue through, so the RRT nurse first opens up the app and just checks to see if new patients have shown up who are either high risk or are meeting the sepsis criteria. At that point, they call down to the ED, have a quick conversation with the ED physician who still has the authority and the autonomy to diagnose sepsis in real time. If that conversation results in the diagnosis of sepsis, the RRT nurse says, thank you very much. I'm going to help just track bundle completion of that 3-hour bundle on the back end. He or she hangs up and then continues to track completion of the 3-hour sepsis bundle as it's completed in real time. So in terms of overcoming the failure to see, really that manifested taking that workflow and putting it into a Microsoft PowerPoint presentation. So it was not any presentation. It was the Sepsis Watch Complete Guide. This presentation, I would say it's more of a complete deck. Took me about 100 hours to complete. And in a way, I'm glad that Suresh isn't here to hear that, but there was a reason for it. It was a soup to nuts approach of communicating the vision, and then the how-to, and then the who will support me kind of effort. So starting from the top, it talked about what is Sepsis Watch, what is the problem, why is it my problem, and why is Sepsis Watch the solution to that problem. The next big section, which was of vital importance, I think, was the how-to guide. So whether trivial or not, tried to document every single step as I learned it in real time interacting with the app. And then we got into the Sepsis Watch workflow, which you saw on the previous slide. And then lastly, I think perhaps most important, and you would see a sigh of relief on the faces of the folks that I was training, was the kind of in-depth support that we offered, which I'll get into in just a minute. So here's a look at one of those slides, just in terms of the effort, just to try to make it as comprehensive and yet as easily ingestible as possible. So really went through the steps of trying to make it approachable. The second failure that we overcame was the failure to move. This really focuses on the fact that the vision and the plan is in place, but the next step and the path forward is unclear, or there's a lack of confidence that that next step or path can be achieved. And so the way we overcame that, as you might expect as well, is really just to meet with all of our RRT nurses. So I held about 30 one-on-one training sessions with each of the RRT nurses, which I actually used the how-to guide to train against. So would start actually with this one-pager to communicate the vision. There's a lot going on there, so I don't expect you to read through it all, but it replicates a lot of what Mark talked about with framing the problem and why it's our problem at Duke. So the current, or the then current, sepsis rate bundle compliance in the top left, followed by the setting in which that sepsis criteria through our analysis occurred, compared to the fake news score that we were working with, which was the status quo, and to really hone in on what the vision was and how we thought that the RRT nurses would help us walk through that vision and make it a reality. So we took all this content and we compiled it, and we actually put it on we also took, we created a Sepsis Watch feedback survey, which I'll go into in just a little bit as well, but the hope there was to collect valuable feedback in real time to then update the app and the workflow per our RRT nurses and our ED physician and nurses' perspectives, knowing that they soon had become the experts in the day-to-day operation and use of the app. So we took all this content and we actually put it on a comprehensive training site for all of our users and those who we were pitching to go access and train. So I would say perhaps the most important thing that we did in terms of build to integrate was to establish the Sepsis Watch Governance Committee. And you see all the members there on the right-hand side. I want to point out really actually there's only 2 that are in the box, but it's really 3. Those are the frontline users of the app and the workflow. And so we found that really after the first meeting in December, those were the users that really knew what was going on, that could communicate the urgency and the relative priority of the problems that they were seeing such that we could respond to that and help focus our efforts in terms of optimization of both the app and the workflow. So the third failure, which is sort of a misnomer in that it implies that there is a finish line, but it's failure to finish. And really that is the idea that fatigue sets in, the lack of clarity if I'm actually doing anything to move the needle. And so I really go back to status quo, even though I was able to start down the right path. And so one of the points that we found to be very effective and what I'm very proud of is the weekly progress report that we started putting out, which was focused on Sepsis Watch volumes and Sepsis Watch bundle compliance rate as it was coming in week by week. So we were able to leverage that infrastructure that Mark alluded to and that Michael and Marshall are going to talk more about to really give a real-time feedback on how we were doing from a bundle compliance standpoint. So week by week, I would send out this report and try to tailor it as much as possible to the previous week's effort to really make it a personal thing and not just a, hey, here's the report, talk to you next week, good luck. So found this to be very exciting, actually, and so by the end, we had seen really between 50 and 80% compliance range for the most part. Wasn't a big fan of the week of, what was that, like 4-1. But other than that, we had a very successful and rewarding experience through this mechanism. Actually started getting emails from hospital leadership and from the RRT nurses themselves just saying, really appreciate you calling this out. You know, it is giving me the momentum and sort of the inspiration I need to know that there's something that we're doing that is having an impact, even knowing that it is a subset of perhaps what is happening in the hospital. So one more thing is that we took that feedback from the nurses through that Qualtrics survey, and we were able to prioritize and quickly iterate on the updates to the app itself. And I think the main message that conveyed, in addition to the actual help that it gave to our RRT nurses, was that we were listening to them and we wanted their input, and we used that input to make their work easier. And so what you're looking at here is actually an example of the decoupling of the comment and movement functionality on the app, wherein previously you had to, in order to give an update on the patient card, which is what we call them, you had to move the patient to either the screened, monitoring, or treatment tabs in order to kind of leave that status update in the comment field. And so we quickly were able to update that, remove the requirement of the movement to leave an update, and helped them with communication with the other users, and especially during the nurse handoff period. So I'd like to finish with just a quick look at the preliminary bundle compliance results that we've seen thus far, which is, I think, very promising. We're currently working on a more extensive and comprehensive analysis of our performance, but really the in aggregate bundle compliance from 2016 through Q3 of 2018 on average was 28%, and saw that in the fourth quarter of 2018 and the first quarter of 2019 we saw an aggregate 63% Sepsis 1 bundle compliance. So pretty exciting results so far, and we'll be sure to keep everyone updated. And so next up is Marshall and Michael to talk about build to scale.
All All right, so we're going to use this, some of the time that we have left, to talk about how we actually brought these models, from research, like you all have been doing, to actually, to the bedside. And we want to focus on the tools and sort of the infrastructure that we built so that we can enable, future work. We don't see sepsis as the last thing that we're going to be doing. We really want to make sure that we, again, we scale where we have more capacity. So as Mark mentioned earlier, the number of projects that we've worked on from year to year has grown, very quickly. And our capacity hasn't really kept up. And so we have to try to think about what are some ways that we can increase our capacity to do these types of projects. And so we were sort of brainstorming, and we like to take a lot of inspiration from industry. So we thought, what would industry do here? And so the first thing I thought was we can just outsource this, right? Unfortunately, HR and a few other people didn't really approve of that, so we had to come up with a plan B. How else do we actually increase the capacity? How can we work on more of these projects? And really, plan B is to build tools that work for more than just sepsis, right? Instead of just building something for one particular use case, what are ways that we can build tools that scale beyond projects? So here's sort of a typical project timeline. This was actually put together before we actually, finished the sepsis model. So this is sort of back in 2017 and 2016. And this is a lot of time is spent doing data processing, actually building the model, working on the implementation. And what we realized was, we're spending too much time doing data processing and data cleaning because we do the same thing for every project. And there's been a few talks at this conference that have talked about this very issue. We spend a lot of time working on, implementation, getting into the production system. Maybe we can sort of cut that short. And ultimately, the vision would be so that each of our projects looks more like this, right? We're sort of compressing the timeline so that we can, iterate on more projects and essentially be more effective with the same number of people. And also, we want to scale our reach. So we don't want to just build sepsis at one university. We want to scale this model beyond the walls of Duke. And so we've managed to bring the sepsis model from our main hospital, Duke University Hospital, to Duke Regional and Duke Raleigh as well. And we're currently exploring partnerships with places like NYU and a few other sites as well. And I'm going to bring it over to Marshall now, who runs data engineering at DHI, to talk about how we actually bring these research models and sort of bridge the gap to actual production. So.
Hi, I'm Marshall. I'm data engineering at DHI. I guess I'm the whole department for right this minute, but we're hoping to expand that a little more in the future. So I'm here to sort of fill in the gap here with what we do at DHI. So we use three main tools: Docker primarily, Apache Airflow, and RabbitMQ. These make up the bulk of our infrastructure. So first, look at Docker. If you're not familiar, this is like a laptop, but it's a laptop that's built for a very, very specific purpose. So imagine you have a laptop that's only for accessing your email or only for browsing the web, except in my case, I have a Docker container that's only for TensorFlow 1.6 or Postgres 11. These give us control of our environment. These let us really be able to deploy what we need where we need it. It lets us orchestrate really, really well and maintain our system in a way that's both performant and flexible. If Docker is giving us control of our environment, Airflow is giving us control of our code. So Airflow uses these things called directed acyclic graphs. You can think of them as to-do lists for code. These are the things I need to execute at this time to make sure that my model gets run or my data gets extracted and cleaned. These are all codified. They're version controlled. They are monitorable. That's one really nice thing about Apache Airflow is that it keeps metadata about all of our tasks. It keeps performance information. How long did the task take? When was it run? When was it started? Was it delayed for any reason? It gives us logs. It gives us control of execution. I can log into the web app and turn things on and off as needed. I can restart tasks that were run a year ago, and they will run exactly as if they were run January 1st, 2018. So for sepsis specifically, we run about 2,000 tasks a day. So these are multiple DAGs. I think it's something like 10 or 15 DAGs that end up spawning 2,000 tasks a day. Fetch and clean tasks run every 5 minutes. These pull from Chronicles, which is the live system behind Epic. We run clinical heuristics every 5 minutes as well. So this is calculating our sepsis definition. We run models every hour, and we do quality control log scans every 24 hours. And then whenever the logs get backed up, we run an extra job to clean them off. So we use Airflow for just about everything. So with hundreds of simultaneous tasks going at any given time, how do we prevent something like this from happening? right? You've got a bunch of things competing for resources. You've got TensorFlow jobs and extractor jobs. Every hour we spin up, like on the hour, we spin up probably 30 to 60 jobs, depending on the hour of the day. The answer is queues. So we put everything in nice straight lines. We make sure that specific jobs go to specific workers, and we make sure there's no collisions in our performance. So message queues, you could think of this like it's an in-memory task store. So if Airflow throws 60 jobs at our system, this holds them in memory until things can get to them to clean them up. So what's really nice about RabbitMQ is we can assign specific tasks to specific queues. So if I have a TensorFlow job that needs to run, and I have a TensorFlow worker with all the dependencies for that job, then my TensorFlow worker will always get my TensorFlow job, and my data extraction workers will always get their data extraction jobs. It lets us control dependencies from the initiation all the way through execution. So if you put it all together, this is what the back end of Sepsis Watch looks like. So we've got the web app, which is keeping track of the DAGs and setting up the scheduling. Scheduling passes jobs to the task queue. And then workers for the specific queues pick up their respective tasks, write and clean data to the database, models run, write their output to a model database, and that model database serves the web app that is Sepsis Watch. So one really nice thing about this structure is that most of it's reusable. So the only thing that's specific to sepsis is the DAGs and the machine that's running TensorFlow for the sepsis model and the model code itself. So if I want to, say, add a new model, if I've already got a container that's got all of my dependencies in it, all I have to do is add a DAG and add the code for the model. If I need new frameworks or new infrastructure, say I want to do PyTorch, I can just add a new message queue to accept those tasks, add a new worker with the appropriate dependencies, add my code, and turn it on. So this is typically what we do. We add all these things, and then we add a database for the model output, and we're basically done, and we're up for trial at least. So we can take things like our 2,000 jobs per day, per day for sepsis, and we can turn that into maybe 2,000 jobs a day for every model as we want to add these out. So I'm going to pass this back to Michael for challenges and implementation.
So I've been told I don't have a lot of time, so actually we got it right on the first try. There were no challenges. All right, that's the end. OK, no. Just kidding. How do I go back? So one of the big challenges is that research code is not production code, right? So all of you researchers out there who've written code, I'm sure it's super well documented. Everything runs, all unit tested. So I don't really need to give this slide, but here's what I see when I see research code. So here, on your left, like that's technically a peanut butter sandwich, but we can sort of argue on how good quality it is. What we'd like to serve is like something on the right. So what we've done is we instituted a policy for code review and to make sure that all the code that we run in production is unit tested, and we run integration tests. And really the main focus on this is that the nurses are the people who are actually consuming the model output. And no matter how many times I look at diagnostics or our team looks at diagnostics, we never see the model as much as the actual end users. They are the ones that are actually interacting with the risk score on a day-to-day basis. They see hundreds and hundreds of risk scores, and they can tell us things about the model that we actually don't know, even though we sort of are co-developers. Also, we try to make sure that we don't have training test skews. So actually, there was a talk about this earlier, but how do we make sure that we encode features the same way, both in the training process as well as the serving process? If we're doing the same thing for labs and medications and demographics all the time, let's try to keep it consistent so we can actually unit test the individual feature creation modules so that next time you want to build a model, you don't have to write your own code to find the maximum value of creatinine within the past 36 hours. It's just built for you. OK, the other thing is that EHR is not static or clean, as many of you might know. So we've had things happen like certain values have just changed name randomly. This happened with blood cultures, which was very important for our sepsis model. We actually noticed in production that we had a level of consciousness, sort of variable that somebody decided to just rename, and it just disappeared from our system. So we've built a lot of input monitoring to make sure that that doesn't happen, right? And so a lot of the times, the models that we build will handle imputation, and so it's really hard to diagnose when something like this happens. So we have to build infrastructure. Same things for monitoring the actual system to make sure that we're actually still getting our data. So we have like all these dashboards that help us. There's a lot of other problems which I'll sort of skip over for, we've actually already discussed them today, like entity resolution, unit conversion, things like that. So we also want to keep track of models and their metrics, how well they're working over time. Again, we don't think sepsis is going to be the last model we're going to run. So what we do is we require that every model that we run comes with its own model manifest, which has essentially, the version number of the model, what are the input data requirements, what is the structure of the input data, and we sort of parse these model manifests as we run them to make sure that we keep track of metadata. So we know which model is running, where it's running, what does the performance look like. So we track the metrics, and then we can do sort of like A/B testing in different sites to see how this works. So where this leads us is that we can leverage sort of existing production-ready code to build your features. When you train your model, you can use existing clean data, as Kristen mentioned before. And once you're done fitting the model, you just generate a manifest, you create a container, and then you request a code review. And then as you run, we like to run things in silent mode so we can test to make sure that all of our code is running correctly, that we can sort of track the performance over time, and then we make the results available to the initial clinical pilot team. So we currently have Sepsis Watch in production, and then several of the posters that you've seen today, sort of inpatient mortality, the hyperglycemia, cardiogenic shock, have all used the exact same system, and we're able to sort of scale those out into production very quickly. So I'll sort of wrap up. Really, I want to go back to these three principles. When we were first starting out doing data science at DHI, we realized, like many of you, that machine learning has huge potential in healthcare. And so we really wanted to come back and say, if we're thoughtful about the way that we build these solutions, that we can really prove that to people. So we started by building to show value and working on the right problems. We were hyper-focused on who was actually going to end up using our product so that they didn't really hate it when they were using it. And then we also made sure that we were able to scale this beyond just a single use case and beyond just the walls of Duke. And of course, underlying it all, we wanted to build responsibly. So I'll just end with what our vision is. I think we're all here for the same reason. We all believe in the potential of machine learning in healthcare. We believe that we can build systems and frameworks that enable true innovation in this space. And ultimately, within 5 to 10 years, I hope, and I'm sure that you all hope, that thoughtful machine learning solutions will be ubiquitous throughout the United States and beyond. And that ultimately we can help achieve the triple aim of improving patient experience and outcomes, bettering the health of our populations, and lowering the total cost of care. Thank you.
How y'all doing? Looks like we're about half an hour off schedule right now. Is everyone doing okay? It's an honest question. Everyone doing all right? Everyone awake? Yeah? All right, you guys okay? All right, cool. My name's Lee Hartzell. I'm primarily a clinician, so I appreciate I sympathize with the fatigue. I wish I could give you something, a little stimulant, maybe some coffee later, I don't know. But I just want to talk to you a little bit about our project. I actually presented about this project a couple years ago. I want to give you a bit of a quick update. Really kind of also a transition really from the inpatient setting to the outpatient setting and how machine learning is doing some awesome things. I was talking to Catherine, and she's talking about how, I love MS. I think it's amazing, but I think the things that you guys are doing are just as amazing. It's just really, really cool. So, all right, to get to the point, right? So, here's the problem. Multiple sclerosis, there's more to MS than meets MRI. So, all too often we use MRI scans in order to make our best judgment about how patients' response to treatments are going, maybe getting a sense of where their symptoms may be coming from, and that sort of thing. But here's the reality, okay? 22 symptoms. At last count, 15 different disease modifiers, 88 symptom modifiers, 4 relapse modifiers, and over 100 environmental features that result in symptom fluctuations that look like this. Every single day. Every day. And here's what we actually get when we talk to our folks. We're patients. We get maybe about a month's worth of information about their symptom fluctuations. And you can imagine that that puts us at a massive disadvantage in trying to understand what's going on with multiple sclerosis. We can't characterize a disease that we're not monitoring. And MRI scan is just not doing it. So a couple of years ago, Catherine and I started working on a project where we could try to capture some of this data. And the best way to do that was through a mobile application. It's called MS Mosaic. We released it in October of 2017. It's available nationally through the App Store. It's based on Apple's ResearchKit platform. And here's a quick summary of the kinds of data that we're collecting. There's 2 slides to this. There's a massive amount of data that we're collecting on a day-to-day basis from patients in a variety of different domains, either from the app or from the phone or from paired devices if the person happens to have one. And it goes on here too. So our first objective is, with all these things that are going on, we have to start identifying, can we predict which kinds of symptoms a person is going to start having? But first, a couple of quick slides to kind of give you a sense of a representativeness of, is that the right word? Of the sample. So as of right now, at the last data poll, we've got around a little over 1,700 subjects who've enrolled in the study, who've consented and been contributing data. And the breakdown based on gender is actually comparable to what we see epidemiologically with multiple sclerosis. The mean age is around 30 years. And we've got a pretty decent representation of age since the diagnosis was made and the different types of multiple sclerosis. A lot of folks don't realize that, but there's several forms of MS, the most common being relapsing remitting MS. And here's the data that we've collected from this sample about what percentage of the respondents ever experienced any of the 22 symptoms of multiple sclerosis. And I think that the 2 or maybe 3 most prevalent symptoms are ones that everyone in this room can appreciate right now. Fatigue, cog fog, and mood changes. So, but suffice to say though, from an epidemiologic standpoint, to the best of our knowledge, this is actually in keeping with the most prevalent symptoms that MS patients experience on a regular basis. But can we start to predict which patients are going to have what symptoms? So here is our first effort at that. So with the use of just logistic regression and also a trial with random forests, here are the AUC values for a large variety of the multiple sclerosis symptoms. And we're getting pretty decent values. We're getting 0.926 with vertigo. One of the more prevalent symptoms, fatigue, of a 0.86. Maybe another way of taking a look at that data. It's a bit choppy because, again, we don't have a massive amount of data, at least not yet. But then the next step really is to say, okay, well, can we identify the patients based on the information that we've collected from those multiple pages ago? Can we predict from the data that we're collecting in the app about which patients are going to experience what symptoms? But we can do that, but we also need to start saying, okay, well, it's not enough to know what symptoms a given MS patient is going to experience. It's also about maybe giving the patients a bit of a heads up. Can we start to predict the timing by which a patient may start experiencing various symptoms? And you see a little bit of that here, okay? So this is just based on some Cox regression models as well as random survival forests. So the AUC values are actually, they're not perfect, they're not great, but they're getting good. So kind of what's the utility of all this? I spend the majority of my time, 80% of my time, seeing patients. And I can tell you that if there's anything that they're looking forward to is someone who can help make sense of what's going on every day. And one of the nice things about this is that we can start to really capture sort of this "you're not alone" feature, this sort of ability to say that, okay, at this particular point in time, with patients who have similar symptoms to yours, 98% of them are having fatigue. You're not alone in that. And it gives me the opportunity to provide patients with anticipatory guidance. Don't be surprised if you start to see these particular symptoms in this particular time frame. But ultimately, it also has the potential ability for augmenting our clinical management. So I mentioned that there's 88 some odd symptom modifiers. With time, because we're also monitoring medication usage, we can actually see whether or not our symptom modifiers are having the desired effects, far better than what we've been able to in the small trials that have occurred before. Now, ultimately, this sort of technology will also enable us to do more enhanced research design for symptom characterization, and also ultimately improve our clinical trial designs. So our next steps. Well, I mean, ultimately, we really want to get better at forecasting symptoms for patients, and that's going to require more advanced models, and we hope to be working on those shortly. But we also desperately need to expand the data set. There's about 1 million MSers in the United States. We're currently sampling from around 1,800. Now, the app in and of itself has its own challenges because it's not sticky. And so, oddly enough, I started going to the startup school with Y Combinator back in the Valley, trying to get a better sense of how can we make the app more useful to the patient so that they maintain engagement. We can get the data that we can better serve them in the future. We're also working with a local software developer on the next versions of the app. Ultimately, we also plan on enriching the data set, having folks actually start taking pictures that they feel are sort of capture their experience with a given symptom, and take advantage actually of a social science methodology known as photo voice to process and understand that experience. And then ultimately, of course, we need to get this data at the point of care. And so we're working on ways to expand into a new form that integrates with the medical record systems so that can happen. And that's it. Thanks.
Okay. I vote that we all stand up at least. My watch says I should have stood up like a half hour ago. We need to do a, so does anybody remember what MUCMED stands for? Yeah, that's very good. All right. So we need to do a set change. One of the things that we've done year after year at MUCMED is a panel, and I'm going to give the mic to Dave Kale. Why don't the panel members come down, because we're going to end up moving. We've gone from global, hang on. Okay, here.
Okay, so an annual tradition of this meeting, dating back to when it was MUCMED instead of MLHC, which I think most people here didn't attend and probably don't even know what we're talking about. It is a panel. So I want the panelists to come down. I want the gentlemen who are going to help us set up the table and stuff to please get that rolling. I would love to do an actual break, but I think that'll take too long. But definitely like during the course of setting up the table and stuff, definitely like feel free to move around a little bit and relax, but do not exit. I see people leaving. Don't do it. I also, I would encourage you, especially if you want to, these panels are meant to be panel-led discussions as opposed to table featuring talking heads. So especially if you're interested in participating, I encourage you to come down, like sit in this area, be close to the microphones, that sort of thing. I'm not going to attempt to do stand-up comedy during the course of this. I'm going to let you guys talk amongst yourselves, but if you leave, we will definitely start without you.
Bathroom really fast while all this stuff is being moved around.
I'm going to do the same. Hey, how's it going?
Hey, so where's the person who said we weren't supposed to leave? All right, come on, let's. Oh, who are we missing?
We know what it would find. We don't let the surgeons do that anymore. They just have to keep operating.
Test. Okay, good. All right, if you can hear me out in the lobby, now's time to come back in. We're starting without you. Okay. As previously mentioned, the panel-led discussion is a tradition at MLHC, and before that, MUCMed. And for some reason, it's become a tradition that I, for some reason, have to moderate it every time. So we're sticking with that this year as well. Now, normally what that would mean is you'd be treated to some kind of long Dave Cale preamble where I wax poetic. We're going to dispense with that this year so that we can get back some time and make sure that we maximize our actual discussion time, because I want to dive into some really good topics and some difficult questions related to some of the things that were presented this afternoon. So the overall theme of today's panel is basically going to be about the role of industry in kind of advancing machine learning for healthcare, in research, in translation, and also in deployment, which we just saw a wonderful series of presentations about. And I kind of want to get at not just the role, but also sort of frictions that arise, challenges that we might encounter, difficult questions that we might need to wrestle with in navigating the relationship between academia and industry. And to help guide us through this discussion, we have a wonderful set of panelists who will reflect a variety of different points of view, and in some cases, multiple points of view. So it should be a great discussion. To accelerate this process, I'm just going to start here with Pilar. I'm going to allow each of you to just introduce yourself in turn. And if you feel so, and say whatever you want to about yourself, if you feel so inclined, as I mentioned in the email, if there's something top of mind that you think is like a challenge that's worth calling out that you'd like to see us discuss, please mention it now, and I'll make sure that we add that to the agenda. So without further ado.
Hi, I'm Pilar Osorio, and you've heard from me earlier. So I'm a professor of law and bioethics at the University of Wisconsin. I also run a bioethics program at a UW-associated research institute. I run a lot of things, it feels like, including a research ethics consultation service that, among other things, helps our medical school develop policy. And so when you asked us about, what are some challenges? One of the challenges I see as somebody inside of an academic medical center is that our institution doesn't have anybody whose job it is to sort of make the data-related connections or the decisions about things like data sharing between our hospital, our medical school, and private entities. And so naturally what happened was department chairs came to me. as the person who runs an ethics consultation service and said, we don't even know who at our own institution to talk to, and Google and Microsoft and many other organizations have been asking to buy our data or work with our data, and we don't know what's okay to do and what's not okay to do. So first of all, I was shocked that nowhere in my institution is there any policy related to this. And second of all, when I started talking to people from other universities, they also don't have policies in many, many, many cases. So, and I was talking to some people from companies, and they were saying, when we try to go to a university medical school to talk about, getting images from the radiology department, they can't even tell us who to talk to about that. Like, who has authority in a medical school or a hospital to say it's okay to transfer these data out? So to me, that is a major barrier, that there are just these structural institutional deficits there. So we at UW are working on policy, and I know other organizations are starting to work on policy. I think some of you could play a role in helping to develop those policies.
Great, thanks. I'm Sachin Ketterpal. I'm a liver transplant anesthesiologist on Wednesdays and weekends, starting tomorrow morning, for example. The rest of the time, my background is as a software developer. So prior to my medical career, I was a software entrepreneur, started an electronic health record company, sold that to General Electric, and I was in corporate America for about 5 years. Got tired of PowerPoints, regulatory oversight, and meetings, so I came to academic medicine. Wait a second. So I'm dumb, first of all. And now at this point, with Jenna and one of our School of Public Health colleagues, I lead the university-wide Precision Health Initiative at the University of Michigan, and really try and bridge some of these issues that you've heard over the last day or two. I'll defer my challenge until we get through.
Thank you, everyone. My name is Luca Foschini. I'm the co-founder and chief data scientist of Evidation Health, a small company. You probably haven't heard from it, so I'm just going to tell you a few words about it. Our mission is that to measure health outcomes and disease progression in real-world settings, so outside of point of care. And in practice, this means running studies, most often in partnership with biopharma or even academic institution, that use wearable sensor, smartphone, connected device to collect continuous data directly from the participants. One example of that means using phone interactions and keyboard interaction and voice biomarker to quantify cognitive impairment. And this is work that we just presented at KDD in collaboration with Apple and Eli Lilly, or use activity trackers to measure impairment that can come from multiple sclerosis or heart failure, or even acute conditions such as flu. Company is 7 years old. We're hiring. That's Shim's advertisement. So send me an email if you are a researcher in machine learning interested in industry positions. For challenges, I have one around alignment of incentives, but that's already on the books, so I'm not going to spend any more time.
I'm Catherine Heller. I'm at Duke University and Google.
Yeah. All right. So my name's Omar Bedawi. I'm at Philips Healthcare, based in Baltimore. My original life was as a critical care pharmacist, and I also have a background in public health and epidemiology. And I joined what was a fairly mature startup company 15 years ago that was developing the EICU program, which is telemedicine for ICUs. And I've been working in research and development there for that time. And one of the things we've done back in 2008, we've took our aggregated data from our community of hospitals, which is several hundred hospitals at this point, and we de-identify and aggregate that data and set up a collaboration with our customers and academic partners for the EIC Research Institute. So we do collaborative research with that, and we brought some of the data for the Datathon that we had as the pre-event. So I manage that, and that's a big part of my job today, and as well as designing our decision support algorithms and things. So one of the things that I'd like to bring up as a challenge in designing models, I see a lot of the presentations and research is trying to solve very difficult problems where there's a lot of ambiguity around what's the right diagnosis or decision. And what I find extremely challenging to think about is how do you manage it's easy to figure out how to manage when clinicians agree with the algorithm. And those are sort of easy things. But what happens when there's a disagreement? And we know that clinicians are fallible, and we know the models are fallible. And so if you always take the clinician side when there's a disagreement, you're really minimizing the potential value. And if you always take the computer's side, then you're introducing unnecessary risk when it can be clearly wrong. So how do we figure out in that gray zone what's the best approach to take in those nuanced situations for patients?
Good question. All right, so let's see. I think I wrote that down. I'm going to put a pin on that. I think I want to return to this question around data sharing, which is sort of I feel like we were talking about this at MuckMed like 8 years ago. But I think the reason I thought that would be a good topic to start with, or the reason it seems interesting to me, is you just mentioned, Pilar, all these challenges that you've run into at Wisconsin. I know there have been some recent high-profile cases of sort of weirdness with industry getting access to hospital data. I'm not going to mention any specific company names. Everyone in here knows who they are. Right. And yet, 2 days ago, we had a datathon where a whole bunch of people came in and accessed a whole bunch of data. So there's this weird ambiguity. It's like, is sharing data hard or is it not hard? And when and why might it be hard? When is there ambiguity? Or when are there cases where it's actually really confusing and nobody knows what to do? And when are there cases where you can easily aggregate data from multiple hospital centers and then make it accessible on Google Cloud and let a bunch of people who show up to a datathon access it? So anybody want to volunteer to dive into this question right off the bat? Oh, yeah, there we go.
In addition to my geek role, somehow I've had a policy role in this space as well. Michigan has my academic role is where we aggregate data from, we're up to about 50, 60 hospitals, 11 million patient records for perioperative medicine. But we don't sell that data and we don't give access of that data to industry. That's an assumption we had made, probably wasn't valid 10 years ago when we started the group. We've got data use agreements in place with each organization, academic organization, that says we can't do that explicitly. At University of Michigan, we've taken that one step further to state that we have a data and biospecimen policy committee, actually, co-chaired by our Chief of Regulatory Affairs and Office of Research. And it's staffed by bioethicists, lawyers, Office of Tech Transfer, computer geeks like me, and a broad range of perspectives. And we've held to a very specific guideline that if the patient would not ostensibly be aware that industry was accessing their data, we cannot give access to that data at the individual level. We go beyond HIPAA, we go beyond IRB, we go beyond OHRP. So these words of de-identified, which are let's be honest, false in 2019. No such thing. It's all re-identifiable if you try hard enough. If it's an individual level data or a chunk of a person, that chunk cannot be transferred to industry unless that patient has explicitly consented and used the word industry in their consent, not on page 14 of a 16-page consent, on the first page. So the 58,000 patients that you accessed, whose data you accessed on Thursday, was the Michigan Genomics Initiative, which we started about 6 years ago. Those patients explicitly consented to the use of their data by industry. When we know which industry partner is going to get it, for example, we're doing a cohort study with Apple. We've got 5,000 patients in that study. Those 5,000 patients know Apple is getting their data in a limited data set way. And as a faculty, I get a lot of blowback from my colleagues who say, but there's this really important science I have to partner on, or this is a lot of money they're willing to give me if I can just say that it meets HIPAA, meets IRB, I have all these other checkboxes. I think the culture of because we called it a limited data set, that we can allow people to transfer that data is probably not going to be valid a few years from now, and we'll see a change in this area. I'll stop there.
Just so you know, the way I like panels to run is I participate as little as possible. So if anybody wants to just dive in, keep the conversation going, by all means, go.
So maybe just to be a little bit devil's advocate here. So the tone of, and full disclosure, right? I'm from industry, but my background is as a clinical pharmacist. And those of you know who clinical pharmacists, it's sort of in our genetics to be adversaries with pharma and industry. So I've always had a little, schizophrenia there. But looking at what you just spoke about, it has this implied tone that if industry is working with the data, it inherently has potentially nefarious purposes, where I would argue potentially that a lot of the innovation coming out of Michigan research may turn into industry and have the same motives and direction. So how do you make that distinction?
I completely agree with you that is an inaccurate assumption that we make. Having been in industry actually half of my career, and now the majority of my funding comes from industry, actually. I think it's not about what industry is going to do with it. I think those same nefarious behaviors are occurring in academia. I think the question is, what is that patient perceiving when they come to your hospital? Are they coming to their hospital thinking that their data or their biospecimen is going to be in industry's hands? When they come to a university of blank, we have a consent process that says you're at a research university, we're going to do use your data and biospecimens for a variety of purposes. In 2019, and that's why this changes. You can be right one decade and wrong another decade, and I'll be wrong a decade. I'll be wrong probably tomorrow, but I'll definitely be wrong a decade from now when those perceptions and contexts change. We don't believe that patients perceive when they come to a hospital to receive care that naturally that data would be flowing to another industry partner. Many of them want it to. We just want to ask them, and we want to create a model where it is easy for them to. I want to. My parents wanted to, which is why our data is in that data set. So when we talk about, this is friends and family, so we completely agree industry is essential to making progress, but I don't think that's what a participant would expect when they show up to a hospital.
And if I really want to agree with this, right, that this is not, people come to your hospital not to be a participant in research, but to receive care. And they often don't feel like they have a choice, and maybe depending on who the payer is for their healthcare, they might not have a choice of coming to your hospital or coming to particular units in your hospital that are making decisions about whether or not to share data. And this is one of the reasons we've been reluctant, is because if you look at empirical data on what patients expect and what they want, and frankly, even what explicit research participants expect and want, there is more reluctance to share data into the commercial sector. And I don't think it's necessarily because people think something nefarious will be done with it exactly. I think part of it is that they sort of feel like, well, if someone's going to make money off of this and I'm not, that seems inappropriate. So, okay, maybe we need to have a conversation with people about how does medical benefit actually happen in a society where product development is done in the private sector. But I think it's partly from knowing what, in the few empirical studies, knowing what people think and say. For instance, Lucila Ono Machado has a paper where they built a website and let people go on and specify how their medical data could be shared. And sharing to commercial partners was like the lowest, right? That was the thing people were most reluctant to do. And so that makes us then reluctant to just say, well, we think it's okay for us to decide on their behalf that it could be shared.
Yeah, something too? No. I saw you like you were getting.
Yeah, no, I do have something to say, but you go first.
Oh, okay, thanks.
It's the most polite panel ever.
Appreciate that. Thank you. I wanted to, I've been reflecting a lot about this, coming from the world of computer science, of a PhD in CS, and observational data is what it plops in your machine. You don't even think that at some point it was collected. You just analyze it, right? And then shift it into clinical research in which there's this process of consent that's really ingrained in everybody's mind. And it's 10 pages of every single thing that this data is going to be used for, and to make sure that people actually understand it, there's actually a quiz at the end, right? There's a comprehension quiz. It's like, not only you read it, you really understand it. That's a big change. And I'm like, well, the data that we collect in our clinical study goes through this scrutiny for consent and understanding that has never been applied to all the data sets that I worked on when I was a computer scientist. And I resonate a lot with Sachin when he says, well, maybe things are changing. 5 years from now, we might be looking back and say, hey, this analysis that are done in observational data sets with unclear consent maybe just was not the right thing to do at that time. One quick comment to conclude that. 2 weeks ago, there was there's Sage Assembly. It's an open science gathering in Seattle hosted by Sage Bionetworks. And there was a really nice quote, a concept there that was introduced that struck my attention. That's called the concept of data visit. It's not that you use my data, but you come and visit my data. So when you visit me at my home, you need to go by my rules, and you have to be aware that that piece of data still I own it, and I'm watching you using in a way. And this was by the founder of FAIR, Moen Barents. So I think maybe thinking more about data visit instead of data use immediately gives you this idea of, yeah, of course, like intention is important and needs to be considered as the most important thing.
So I'm going to go with, I actually think this mentality is a huge problem, right? Like, I think, to me, the most important thing is making medical progress to help people who have really bad diseases. And secondary to that is satisfying the perception of people who, think something is going to happen with their data. I don't think bad things happening with your data are good in any way whatsoever. And, I would never, ever condone anything but absolute regulation of that. But I think that all the time, routinely in society, as Luca said, now we do things like, Google will scan your email for ads, right? I don't think using your email, writing an email, you thought in any way that you were giving consent to that happening for ad purposes, right? And so, I agree with the consent process, right? But I don't agree that we should hold up innovation in the healthcare space in order to really, what it is, make people happy, right? And so the idea that you can come forward with something that ends up on the front page of the New York Times, that's frightening, but not necessarily enough that I wouldn't want to do healthcare research.
I guess I would ask, why is there a tension there between innovation and individual agency? Because I don't think this is about happiness, because we got miserable people signing those consents. It's about the reason you're willing to give your privacy away is the convenience you receive personally. I use Gmail, and my life is easier because of it. I have chosen to give away my privacy, and that's a choice I made. And I think the concept of agency, particularly in healthcare in a field, I'm guilty as charged. I'm a doctor, paternalistic. We used to tell patients, this is what you should do. So we have, by no means, healthcare has any right to stand and say that we are the purveyors of the right way to treat an individual. We are complicit in errors historically. But in our process, so that data set that was used on Thursday, we ask every single patient who comes to our operating rooms, and now we're asking patients in our clinics as well, 75% of them say yes. But we should be asking them, and if anything, I'll be honest, you're absolutely right, the research consent process is held up to a higher standard than we actually hold our clinical consent process. And that's embarrassing to me as a clinician. We will do things to a patient without really giving them a choice. We're going to go ahead and take you to an operation, and I'm going to do a general anesthetic. And we don't tell them the 8 things afterward. So we've got a lot to learn, but there's not a tension between doing good and doing right. You can actually do good the right way. It's always harder. It always takes more people, it always takes more resources, but we shouldn't somehow think that medical innovation needs to be quicker or less resource intensive. We should give people agency and the right to choose.
Okay, so I guess I'll ask you about, say, something like outside of a hospital setting, right? So say, like, take search data at some tech company or whatever, right? That set of people was not consented to have that information used for healthcare purposes, right? Now, you could start consenting those people, right? It would take you a long time to get potentially a significant amount of data. You're missing the time interval in between what data you have collected and now. And it's not clear that consent rates are going to be necessarily as high, it depends how you phrase it, right? Necessarily as high as going into surgery. What I've seen is that when people are sick, people are very happy to give their data away, right? Like, I'm sick, if this could help anybody in my situation, if there's even a remote chance, I'm really happy for you to use my data, and I really don't care about data privacy at all. If somebody is not sick and it's going to help somebody who has some other illness, right? It's not so clear. Like, they're like, well, I don't know, somebody could come after me and I'm not sick. So I think there's a question of, like, how do you also explain to healthy people the benefit to sick people in a way that they understand, in a way that supersedes, like, their tendency to want to keep their data private because of their own self-centered concerns.
But so I think we all have self-centered concerns, right? And the point is that when you have a very serious or chronic illness, then your trade-offs are different, right? Because how you could benefit by the use of your data, or people very much like you, maybe your kids could benefit by, or your family members could benefit from the use of your data, that is actually very great at that moment when you're making the decision. So, I mean, that's also a self-centered way of thinking, right? So I think it's self-centered either way, and we should accept that. But the other thing I want to say is that, health is a really important value, but it's not the only important value. And you were using the examples of, like, well, we basically have been surveilling people's Gmail and so forth and using that information. So the Annenberg School in 2016 did a study where they asked people, do you perceive that you are making an informed trade-off of trading away your privacy for benefits that you get on the internet? And that's not how people understood it at all, right? People understood it as things like Facebook have become so integral and central to life that I cannot live a full life without it. And I feel extremely coerced and disempowered because I feel like I don't have a choice, like especially people whose business somehow used Facebook or Gmail felt like they didn't have a choice in using it, but they felt extremely disempowered and disrespected. And, that's not, I frankly think it's not a good way for anybody in society to interact with people, but particularly the healthcare system, right? Where people come to you and they are vulnerable and they can't, maybe you could live, I live my life without Facebook, and I live my life without Gmail too, by the way. But, no, really.
Intervention.
But I feel like I cannot actually do without some degree of healthcare, right?
Yeah, no, that's correct. Though I feel like, okay, so I agree that everybody acts in a self-centered way, right? But, like, I think there's a value judgment on my part that the self-centeredness of somebody who has a chronic disease and the promise of being able to potentially make their lives better is more significant than somebody's, like, unfounded concern about privacy. Not even their founded concern about privacy, but somebody's unfounded concern about privacy, which is potentially significant in our society, right? It's a lot, and it's a lot of people. If all those people would withhold their data, like, it would definitely impact a sick person.
Luca? Yeah. Maybe one thought is, if we try to set ethics aside for a second, which is never the right thing to do, but let's just, just do this mental experiment, and we make a purely utilitarian argument on what is the cost of a data breach? Like, how wrong can go things that people are so worried about? I mean, oh, okay, disclose a PHI, what happens? What really happens? And we tried somehow to quantify that, and we weighed it against what is the loss in medical progress, which probably is hard to quantify, but maybe we can put a weight on that. I feel like a lot of people reason on this framework, and I'm not sure that's the right way to go. It could be a false dichotomy, because really the question you should ask is, how much resource do I need to invest to reconsent people? That's usually just taken off the table. It's just like, no, it's impossible. The rates are going to be too low. We also lost the records. So they're never going to say yes. But at Evidation specifically, we run also a consumer-facing platform, and we really went from, try to, use data that was already collected with broad consent a priori to actually reconsent people even for diverse use. Yes, we had to put in place an infrastructure to allow that to happen, but it did work, and the rates are really high. So maybe there is a chance to do the right thing and not hinder progress for too long.
And think about that engaged community. You've got by the process of consenting, you actually need more data. Let's be honest. The biggest problem here is not algorithms, it's not CPUs, it's not GPUs, it's well-tagged data. So when you're looking at the MS project, getting someone to actually answer a question every day, is today a good day or a bad day? In an unconsented world, they're not going to answer that because you can ask them that question. In a consented world, you create the potential for advancing science much more meaningfully because you've got a community of people with you. They're actually bought into the concept, wait, medical science needs me to advance as opposed to medical science needs my data. Subtle difference, but that effort, I completely agree with you, generates potentially what we're actually missing in machine learning, which is the tagged features of the outcomes. We got features ad nauseum. We just don't know what actually happens to people in the end.
I think Jim Fackler would like to make a comment from the audience.
What was the clue?
He's been staying there for 40 minutes.
So we've actually made it almost 3 full days without bringing the IRB up, but I'm on our IRB. And one of the challenges that we've got is, yes, and the IRB is to protect the patient, it's to protect the institution, but we also can't approve anything where the results of the analytics won't be right, won't yield a legitimate result. And one of the challenges is, now having learned that 25% of the people who were approached for the data we used on Thursday said no. You have to wonder what the biases are, what the ethnic or racial biases are in the people who chose not to consent, and whether we're going to end up doing melanoma analytics on white people, and then you go into a group of blacks where it won't work because they didn't trust the system and wouldn't sign for consent. So, and I think we should be approaching this as the data as a public good, and we should be waiving consent far more than we currently do. Go ahead, tackle that one.
Yeah, I think this is a huge problem. The bias introduced from missing data under this paradigm, and I believe that, one, we can take into account and really protect patient privacy and do good science, but not necessarily fully need consent in every type of analysis and data aggregation. And so you can make sure their concerns are addressed, but not have to physically go through consent each time. And
I'm not saying people shouldn't be told. I'm just saying, and people need to be informed. They need to come in. They need to know that the data will be used for good and not for nefariousness, regardless of whether it's academic nefariousness or industrial nefariousness. But once informed, the public health is a big deal, and these analytics are going to be a big deal. And if we're going to use, if we're going to use the microscopy to create an algorithm to pick up cervical cancer, you need everybody involved, or we're going to get bad results. And even the people who have signed the consent forms are going to get results that are bad.
Yeah, just one more thing. One of the things that I recall that really struck me as a problem years ago, we were talking with a big company that was making clinical data repository out of medical record information, and patients would be able to control access to the data, and they were adding in features that would allow patients to say, yes, you can use this for research, but they could also hide certain parts of their medical record that might be used for research. And the thing that comes to my mind is, imagine if everybody with mental health issues or HIV decide to hide that. Then all the research you're doing on that data set, you're completely blind to that issue being there, and you're going to make tools that potentially could be very harmful to that population because you're unaware of what really is happening with them because you don't have that data and it's just hidden.
That's a tricky point. I actually would be perfectly happy to just go on talking about consent for the rest of the panel because I think this is actually kind of a fantastic topic that has connections to other conversations that are happening in society right now. I wonder if maybe if anybody would like to make a concluding comment, maybe you, Pilar, about how we can kind of think constructively about this topic. What I loved about this conversation is I feel like when this conversation's happened at this meeting before, it's usually like, it's about like sort of, administrative questions around, like how do you convince your IRB to blah, blah, blah? How do you write your DUA, which is like an exhausting conversation. I love this because we were really just like we got to the crux of the issue, which is should we be getting consent or not? And what are the implications? But I'm wondering like, what are ways we can think constructively about this as a community and make progress on it and not talk ourselves in circles? And then we can move on to the next topic, which is going to be incentives. Yeah.
So I could say that there are different models in use, right? So this idea that you want as complete a data set as possible. So Vanderbilt's BioVU, they use an opt-out model where basically everybody who gets healthcare in their system their data are so-called de-identified, put into a repository, and if they have certain medical procedures done, a biospecimen is also saved. They can opt out. And very few people do, and it turns out probably very few people really know that they can, but they're supposed to get notice that this is happening, and then they have procedures to opt out. So it's setting a default in a way that you assume that most people would say yes, and that this is enough it honors their autonomy and their choice and their need for a choice enough, right? So that model has been heavily criticized, but it's being used, right? And it does give people who really, really care and really don't want to be participants a way to pull themselves out. And a lot of other people, frankly, maybe the degree of their concern is moderate. So that's one model. Another model is just to give notice and no option to opt out. And then we have the much more robust consent model. I guess the last thing I would say is that I don't think consent is just about people wanting to protect themselves from bad things happening, right? Choice matters to people, and feeling like you have agency matters to people, and I think especially in relationship to your interactions with your healthcare system, which can be very daunting and kind of a little dehumanizing. Choice matters, right? And so one of the things we see in situations where people have reconsented and then they've studied the people both who gave consent and didn't consent, even in situations where very high proportions of people reconsented for data sharing and they said yes, most of those same people also said, it really mattered to me that I was asked. And it wasn't that I was concerned that horrible things were going to happen to my data. I trust you enough to use adequate security and so forth. But it matters to me to be asked and to have that sense of agency. So I want to leave us with the idea that this consent conversation is not just about privacy and data security. It's also about people having a sense of agency.
Thank you. That's a good final note. Luca, do you want to kick off the question of incentives and aligning incentives and that sort of stuff?
Yeah, so there hasn't been a question, but I think the question is there alignment of incentive in healthcare? And I think it's a kind of a moot question because the answer, obviously, no. there's not. And usually, they show.
You want to clarify for those of us who are like less savvy in the room, or like, oh, I hadn't really thought about that. Like, sort of give us a little more detail on which incentives you think in particular might be misaligned and why and that sort of thing.
Yeah, I think that one that we see constantly on the news is payers and providers, at least in the United States. And so payers are insurance company, that's the technical name. The cost of healthcare is ballooning. No one is really interested in pushing it down. And that comes from the fact that providers have interest in charging the payers more, and the payers has no interest in changing the status quo directly. The point I had myself is that it seems that there are many situations like that in healthcare in which there is kind of like all the players are in a sort of a natural equilibrium. Like if each of them moves by themselves, they're getting a worse off. So you need to partner and convince a subset of people to all move together. And the example for us, so we work a lot with pharma, so I'm more on the clinical side of things, is developing new measures to approve drugs. So new endpoints in which drugs are approved. No pharma company itself want to undertake that because that new measure that will make trials faster and more efficient then is being used by everybody else. So they will have to invest the cost of R&D for a return that then is of everyone. So no one will move first. But as soon as you create a consortium of pharma people and regulator, and that measure gets developed in a pre-competitive way, then everybody has interest in doing that, and like things move pretty quickly. So my thoughts or recommendation is we tend to see a lot like, oh, there's a misalignment of incentives, tough luck, right? I hope that the regulation will change, and I will wait until then. But maybe a better way is just like, who should I partner with to make sure that the group of people that I'm partnering with all together has an incentive in moving forward that's automatic.
Who else would like to dive in on this topic? Omar, I see you moving. Oh yeah, great. Let's hear it, man.
Great. So yeah, on the one hand, I think the idea of the public good view is compelling in a lot of ways. Like, in some ways, health, is a public good. Like, should people have consent about opting out of vaccines? Whoa, that seems extreme. There are some, I think, corner cases that make me uncomfortable. But I also think that a lot of these questions are not anything near that level of intensity. And so I wonder, I guess it's a question for you about this board of bioethicists and lawyers. Is there a dedicated patient advocate, kind of like a public defender whose job is to speak for the patients, but also maybe just randomly survey and call patients and see, what do you think about this thing? I want to speak on your behalf. And just have someone whose one single role, that's the incentive hook, whose one single role is to be the patient advocate, as opposed to a researcher who cares about ethics or a lawyer who cares about getting sued or something.
So we have a patient and family-centered care group that we work with, and the problem is we haven't found how to get one single individual on the committee to reflect the community, because oftentimes what happens, the NIH has found this, is that we tend to have an individual and we use them as a token individual to reflect a couple million people, which doesn't always work as well as you might hope. So what we do is we actually take 10 people and use them to represent 1 million people instead, just like all of us do in our derivation and validation cohorts. And we found that way works a little bit better. So we work with our patient family-centered care group, who is essentially our conscience in that area. So because they are then connected to another 100, and that 100 are connected to a larger committee. And that is a bit more sustainable than a patient representative on that committee. But completely agree that a bunch of researchers, even though we get sick and have healthcare times, we're not reflective of the group we theoretically claim we are advocating for or serving.
Thank you.
Yeah, I would say medicine also has a similar kind of patient engagement organization within the healthcare setting. So it's a whole panel of people and a way of having various community conversations so that you don't just have one person, actually. I want to go back to this incentives thing, though, because I thought that was lovely, and it's all about overcoming the collective action problem. And it seems to me this is where NIH also can play a role and has in the past sometimes in like the genomics world played a role in bringing together pharmaceutical companies and academic researchers in the quote pre-competitive space and also funding some of that work so that nobody feels like no private entity feels like they're the ones putting in all the money that everybody else is going to free ride on, the outcomes later. So I thought that was beautiful.
Anybody else have some thoughts? But before that, actually, maybe what I'll do is, as I'm watching the clock count down, I'll maybe expand the scope of the question a little bit and talk not necessarily so much, not focus or restrict the topic to incentives and thinking about alignment of incentives, but even problems. Like what I'm curious about, or I guess what I'm really getting at is, are there any perceived gaps between sort of the interest of academic medicine and machine learning and as a specific subset of that, of the kinds of problems we're working on, the things we care about, the things that, the goals, the aims, et cetera, and then between that and the sort of work that folks that are in the industry, that are on the business side of healthcare are interested in? Is there misalignment, maybe not necessarily in terms of incentives, but maybe in terms of problems that folks are working on, in terms of challenges that come up, that sort of thing? So, and I guess I'm really looking at the three of you at the end there, like, especially to the extent that each of you has like made kind of a little bit of a transition, had some experience of being on one side and also being on another side. And like, are there anything that surprised you once you start engaging with a private company that's interested in this space where you're like, oh, I didn't realize that was something I never noticed or never cared about when I was purely on the academic side. Now I see this is a problem of interest once you think about healthcare as a business.
I mean, I would actually say that I think that healthcare was a business regardless of what environment I was in, right? Like when I was dealing with a hospital in an academic setting, it was the motivations at the end of the day were business motivations. And I am sure, though actually I've been told less directly at like a tech industry company, right, that the motivations are business motivations. I'm sure that's still there. So I think for everybody that I've worked with, regardless of whether it's in academia or an industry, and I think their strengths are potentially different, right? It's business at the end of the day, and then what they've said to me personally tends to be just focus on your research.
Yeah, I mean, I agree with that, and I also, something you said earlier in your talk resonated well, which is about how researchers don't want to deal maybe with the emotional front end of the users and the implementation. I think that gets to the idea of how siloed things are and how people tend to be very myopic in their views of what their role is. And I think it's very common in academics to be motivated by the advancement of new novel methods, publishing, getting it out, but how that necessarily translates into practice and dealing with that insanity is too much for them to deal with, and that's for someone else, and they're just on to the next paper. And so there's not a lot of great follow-through when their motivation is to just keep developing new things, but not necessarily be in that world that takes it full circle.
Yeah, absolutely agree on that, and I would even say more that in science, maybe in tech in general, we have this belief that if there's something better is being presented, it ought to be adopted, it will be adopted. But in reality, the burden of communication is still on who develops the method. So really go into like doing this constantly evangelization in a way that this thing needs to be implemented is important. The other point that I wanted to make is that difference between the gap you're asking, the gap between academia and industry. I feel there's one that's big and that's natural, and maybe we don't have to try to solve it, we just have to observe it, which is academia feels is about more science, so generalizable principle. So we, for instance, see generalization across many data sets as being a value, is a surrogate for trust of a method. And industry, on the other hand, is more of an engineering problem. It's more like is really overfitting a solution to your specific problem and make it work in your case. So I'm thinking of bridges. Like you build a bridge, you don't have a science of bridges. Like every bridge is very different from each other. Now you have a material science, but that's very very much high level, and doesn't go into the implementation piece. And I think Suchi in her talks also has like this division between engineering and science, which I think is a crucial one, and does not need to be resolved. Maybe that's just the way it is.
I think one interesting thing with the industry is that we somehow in academia paint industry with a single brush. And that's so not true, whether it's entrepreneurial industry, classic device industry that I was in and at GE versus pharma. They've got their own cultures, their own paces. And the most exciting thing is that now as Amazon and Apple and others are coming to space, the pace of change that the tech industry expects, Google's coming, is just a factor, multiple factors different than our classic make a drug, phase 1 trial, phase 2 trial, 10 years later, I have a drug, it doesn't work. That entire iteration is like a month these days. And healthcare and doctors we are so not ready for the expectations that our patients have now that these entrants are coming in. So we've gotten pretty comfortable with the culture of, I think, a pharma or biotech industry and the other industry, and it's a wonderful change. It's spectacular. I think we have to embrace it because fundamentally we are not scientific. We go to med school, we do all these things, we claim we're scientific, but the evidence underlying half of my decisions on a clinical day are usually non-existent, and the rest is just preference. And we just need to admit that and admit that we have to have these new entrants completely rewrite, but I don't think any health system, including my own, is prepared for the shift that's coming and embracing it.
Yeah, and I think you said something really important there, which is I think the change is going to be patient-driven. I think it's entirely going to be patient. It's not going to come from inside hospitals or inside any institution.
Could I, so I actually have a question about gaps, because I feel like there is some kind of gap. So at least from an academic perspective, the scientists I work with and the clinicians I work with feel as though they either have to be a full collaborator with industry, or the other option is we just sell our data and they walk away with it. And I feel like there should be some middle ground, right? Because I actually think it is very crucial that products tend to get developed by industry and way, way better than they do in academia. So we need to get that data into industry. And at the same time, I worry that, the whole sell and just walk away with it model actually might not lead to very good products, because it might not lead to a deep enough knowledge of the context in which the data were generated, for instance. And at the same time, it is not going to be possible for, any particular healthcare system to have robust, full collaborations on all the things industry might be doing, right? And so I feel like there needs to be there's a gap there that somehow needs to be filled, but I'm not quite sure what it would be filled with. So I would love to hear any ideas, actually.
So, that was actually a big part of the motivation of us creating the EICU Collaborative Research Database. I've been working with that data for 15 years. I have a clinical background. I work with the software engineers that develop the tool. We work with the clinician users, I understand their workflows, and I understand how difficult it is to work with that data. And so we won't just, even within Philips, give the data to other groups in research and say, sure, go ahead and use it, because I know they can't use it correctly. It's just, there's too many things there. And so what we did is we tried to take an approach of crowdsourcing, where all the information shouldn't lie within me and my team, and it's too hard to scale us up. And so what we did is collaborate with MIT and the Lab of Computational Physiology that manages MIMIC. So they have experience with that. And then we took 200,000 patients, have made it publicly available through a data use agreement. Everything's obviously de-identified and certification and everything. But now there's a ecosystem for sharing knowledge on how to interpret the data. And we go around with these datathons around the world educating data scientists and clinicians how to do this type of research, how to try to think about what the underlying data means, how it got there. All those things are very hard, but with hundreds and thousands of researchers around the world sharing methods, then you can start advancing and not have it just tied into one small group with the knowledge.
Anyone else have other ideas they'd like to volunteer on this question of facilitating good collaborations without having it to be either or, all in or sell it and see ya? Thoughts? I know you were doing a lot of this, Luca.
That's right, yeah. But I'm also looking at the timer.
Yeah, let's go ahead. I'm managing the
red.
time. I'm managing the time.
Yeah, so we've had quite good success actually in just applying for federal grants. So DARPA, NSF, NIH, in collaboration with academic institution, and I do think they do realize that having a company building the product piece of it and having an academic partner doing the science piece of it is the best of both worlds, and it has worked very well for us. In fact, when you were showing that. The funding agency still does not recognize apps as a thing that should be funded. We haven't encountered the same thing, or maybe things have changed since it was 3 or 4 years ago that you had the MS mosaic, or even more.
Yeah, it was a couple of years ago for sure, and so things might have changed. But I was explicitly told that by program officers at like federal granting agencies. They're like, "This is not research. We will not fund this." Like very, very straightforward.
So here's a trick maybe. Like we phrase the app as a data sensing piece. It's just like one other sensor, right? It allows the patient to input data, and so it's fundamentally just like the other sensors that you're paying for already, and also increases compliance because you can build a system of incentives in the app. And we have this, we've seen that this works in practice. So next time you write a grant.
Yeah, I'll keep that in mind.
Cool. All right. Well, we're running out of time. Anybody have one last final comment they would like to make? Maybe a last piece of advice to share with young researchers in the crowd who are staring at a very exciting brand new world of a lot of, not just machine learning in healthcare, but a lot of companies entering the field who weren't previously participating. Vigorous startups that are slowly conquering the world, that sort of thing. Any last piece of advice for students who are thinking like, well, maybe I'll head in the industry direction or something? Anybody want to toss one out?
I'm hiring.
Yes, Luca's hiring.
The weather's always like this in Ann Arbor, 12 months out of the year.
Yeah, perfect.
I think we're all hiring.
Maybe there's a nice article for you to read, for all us to read when we get out of here. Chris Hogg, CCO of Propeller Health, is about digital health. Is digital health growing fast a good thing? And the answer is obviously no. But it really applies for anything tech and health. Like things in health are not fast. So be prepared, be strapped down for the long run. If you join a company, it's not going to be a unicorn in the next 2 years. It might take 2 PhDs to actually have something that works. It's not like tech. So chill.
That's good advice. Chill. All right, let's thank our panelists.
Thank you so much.
And here comes Jenna with a few final words. I'm sure it'll be fast.
Thank you, everyone. That was a wonderful panel. Over the last 2 days, we've had wonderful invited talks and presentations. I've seen numerous conversations that looked like the beginnings of collaborations, and I encourage you all to continue to work with one another and follow up with each other throughout the year. And I'd just like to announce that MLHC 2020 will be August 14th and 15th at Duke University in Durham, North Carolina. So you should all save the date. So far we've thanked the program chairs, we've thanked the speakers, we've thanked the area chairs, we've thanked the reviewers, we've thanked the sponsors, we've thanked the presenters and the students who submitted research papers and clinical abstracts, but we have yet to thank our organizers. So would Jeff, Beatrice, Joan, and Jessica please come up to the stage? You're all crucial to making this happen. I can't thank you enough. And didn't they do a fabulous job? Thank you so much. It was really wonderful. And last but not least, thank you to all of you. See you at Duke. Thanks.